In 1796, a German by the name of Franz Joseph Gall proposed a radical new idea to the world of neuroscience. He believed that the brain is the organ of the mind, and certain regions of the brain have specific localized functions that can manifest on the skull. Thus, the practice of phrenology was born. The basis of phrenology is that the contours of the skull can predict personality traits in individuals. By measuring various regions on the skull, a practitioner can assess the prominence of any of the 27 organs that determine a person's temperament. While some of these ideas have a basis in reality, the practice of phrenology was quite a departure from scientific reasoning, and although practiced even today, it has been relegated to the realm of pseudoscience.
Welcome to Clinical Correlations Neuropathology. This lecture will go over some of the basics for central nervous system specimens, including embryology, anatomy, and basic pathology in SurgPath. So as you can see, we have 14 objectives for this lecture covering a wide range of topics. Your objectives are taken from Lestra, Westra, and the ABTA Brain Primer that you'll find on D2L. So feel free to look these over and let me know if you have any questions. So let's go ahead and start with embryology. Now, embryology for the nervous system starts in the 3rd week with the development of the neural plate. This is specialized ectodermal tissue that you'll see arising over the nodal cord, which you can kind of see right here, little dot under the neural plate. Now, the neural plate is consistent of neural grooves and neural folds. Now, during the 4th week of development, the neural folds will actually come together and create a neural tube. And the neural tube will start to fuse, essentially at first, and then moving caudally and cranially until it's left with just 2 openings called neuropores. And these neuropores are important for communication of amniotic fluid within the neural tube. Now, the tube itself remains open and it creates what becomes our primordial ventricle system, which is carried out through the brain as well as the spinal cord. Now, these neural pores are going to eventually close off, and then we'll get a completely sealed nervous system that will go on to create its respective components. Additionally, you'll see surrounding the neural tube are these neural crest cells. These are also specialized ectodermal tissue that come off the neural plate. These are going to give rise to our peripheral nervous system as well as components of our meninges. Now let's take a look at spinal cord development. This one's pretty straightforward, and starting with the 4th somite and moving caudally, the neural tube will develop into the spinal cord. Assuming everything goes right and the fusions that happen accordingly, everything will just continue on and become a spinal cord with the vertebral column. However, if the neural tube does not close completely, we can get what's known as neural tube defects, or NTDs. And these are just incomplete closures of the neural tube. There's a wide range of factors that can play a role in whether or not these close, including genetic, environmental, and nutritional. In fact, it's encouraged for women who are trying to get pregnant and shortly after pregnancy to take folic acid supplements. It'll reduce the risk of neural tube defects. Overall, these are relatively uncommon, but can occur about 10% of the population. And there's 2 main types we'll take a look at, which are Spina bifida, and there's 2 variants of that, occulta and cystica. And overall, these are basically just 2 variants of non-fusion of the vertebral arches. So first, Spina bifida occulta. This is the most common that we'll see, and this is the one that occurs in about 10% of the population. And these usually occur at L5-S1. And what this is really just a non-complete fusion of the midline of the vertebral arch. So most of the arch is developed, it just hasn't quite fused completely. And these will usually be clinically asymptomatic, but sometimes you'll see a tuft of hair at the location of the defect. These are typically fine and they don't result in any sort of herniation. A lot of times they can go untreated and you can live a relatively normal life. So contrast that with Spina bifida cystica, which is the more severe variant of these 2, and this is a lack of development of that posterior vertebral arch. Now what this means is that there could be a herniation of the meninges, or more dangerously, the meninges and the spinal cord. And so if you see in our diagram here, the meninges has just popped out. When we see just a meninge extending through the defect, we call that meningeal seal. And what I want to point out right now is the importance of naming conventions. And usually I'm not a big proponent of spelling everything exactly correctly, as long as it's kind of close. But here some of the words can be changed ever so slightly and change the complete meaning. So in a meningeal seal, it's just the meninges. But if we add the myelo component, meningeal myelocele, now that means we have portions of the spinal cord coming out. And just remember, seal means like cyst or sac-like protrusion. And myelo will be spinal cord. So let's take a look at brain development now. And this is going to be the rostral portion of the neurotube. So before we get to closing of that neuropore in the rostral region, the brain's actually going to develop into three primary regions, known as the forebrain or prosencephalon, the midbrain or mesencephalon, and the hindbrain or the ramencephalon. Now, during the fourth week, there's going to be a lot of bending and get our characteristic sort of primordial brain architecture developed, which will eventually give rise to the cerebrum and cerebellum and brainstem. And then shortly after that, in the fifth week, the brain's going to undergo a lot of growth and development and sort of start folding in on itself. And then we're also going to see a further division of these three subdivisions, or these three primary ventricle divisions, particularly the forebrain and the hindbrain. So we'll see the forebrain or prosencephalon develop into the teleoencephalon and the diencephalon, which are going to give rise to our cerebral hemispheres and the thalamic regions respectively. Our midbrain will remain relatively unchanged and continue to become the midbrain. And then our hindbrain is going to further develop into the metencephalon, which will give rise to our pons and cerebellum, and then our myelencephalon, which is going to become our medulla. Now, one thing to note again with terminology, we see that myela prefix there. So this is kind of the junction before the brain becomes the spinal cord, and it's kind of like a hybrid spinal cord brain component. The other thing to keep in mind, I told you the neuropore or the neurotube is going to actually have a hollow opening, which is going to be our primordial ventricles. And you can kind of see how our ventricular system starts to develop. So our forebrain here becoming our lateral ventricles, our third ventricle forming within the diencephalon, our aqueduct is in the midbrain, and then our fourth ventricles are going to be part of the ramencephalon or the hindbrain components. So here's that bending that occurs in the fourth week, and you can kind of start to see how the brain is starting to take shape. So we have our, let's see, I'll use the pointer if that works. We have our forebrain region here, kind of bending over, and eventually as the brain starts to rapidly develop during that fifth week, we're going to start to see the development of our sulci and gyri developing on themselves. And then you can kind of see that primordial brainstem here developing into the spinal cord. And so these flexures just help to give the brain more space in a very limited area and allows it to continue to develop and develop and develop on top of itself and get as much surface area as possible. So just like in the spinal cord, we can see congenital anomalies form in the brain itself. These are also relatively uncommon, about 3 in every 1,000 births. But again, the result is the same usually, or the cause is the same usually, a non-closure of that neurotube or that neuropore. So the first two we'll take a look at are cranium bifidum and microencephaly. And microencephaly is sometimes referred to as anencephaly, and we'll get into that in a moment. But cranium bifidum is really just a mimicry or kind of a similar pathology as spina bifida cystica, except this time the defect is in the calvaria, and we see herniation of possible brain tissue. So again, keeping our naming conventions important, a meningeal seal is just going to be the herniation of the meninges, whereas the meningioencephalocele, and that keyword being encephala, means we're going to get portions of brain tissue herniating out. Now, this can be repaired relatively easily and usually has minimal to moderate defects on the child's brain development. And again, relatively uncommon, 1 in every 2,000 births, but repairable nonetheless. Contrast that to microencephaly or anencephaly, and this is a complete failure of that rostral neuropore to close. And what we have is a complete absence of the forebrain, midbrain, most of the hindbrain, as well as the calvarium or the top of the skull. So the problem here is, well, first let's look at the naming convention. When I say this is sometimes referred to as anencephaly. If we take that apart, an means none or absent, so absent brain. And that's not technically true because we do have a portion of the hindbrain present. So microencephaly is really the proper way for that to be called. And now, as you can imagine, this tends to be relatively incompatible with life. You don't really have anything other than your basic functions. I did read an article back where there were some children that actually, they reached up to about age of 4 or 5 with this condition. But typically you don't have a lot of brain function, and you're pretty much just going off your hindbrain components, which will be like your medulla and your cerebellum and things like that. So definitely one of the worst of these two. Next, we'll take a look at microcephaly and hydrocephalus. So microcephaly, now keep in mind that the word here is cephaly, not encephaly. So this just means small head, not small brain, which would be microencephaly. So I would have to mark that wrong on a test. But this is just the smaller calvaria compared to the rest of the face. Now the problem with that is if you have a small portion of brain real estate, or a small area for the brain to grow, that really just inhibits the brain growth overall, and that becomes problematic. And it's very similar to what we see in intrauterine growth restriction or growth retardation. If we have a really constricted environment, the body can't do what it normally needs to do to grow, and this could lead to some mental defects later down the road. Hydrocephalus, now this one kind of is the opposite, where the head gets more swollen and enlarged. And this has to do with the fact that the skull of the child consists of fontanelles, and they're not fully fused into the hard skull that we know as an adult. Instead, they're more pliable and allow for the brain to grow and develop on a normal basis. However, in hydrocephalus, there's usually some sort of inhibition of the CSF circulation, so the cerebral spinal fluid. Now, typically this results in an inability for the cerebral spinal fluid to exit the ventricle system into the surrounding arachnoid space, and usually maybe a blockage around the aqueduct or the fourth ventricle. The problem here is then the brain is going to continue to see an increase of fluid build up within those ventricles, and that brain is just going to continue to expand. So usually when you see images of these, you see really enlarged ventricles as the brain tissue continues to just kind of be pushed to the side, but the head will keep expanding to accommodate that growth. Now, if this happens in adults, that growth can't happen, and usually it just be compressed brain tissue and associated headaches and such. Now, this can be treated relatively easily. The abdomen is usually the source of where you can shunt some of this fluid, because the abdomen is able to take the excess fluid a little more readily than the brain. And if caught early enough, usually you can have mild symptoms or mild mental deficiencies. If it's prolonged, sometimes the brain has just been too compressed, and we can see some severe defects along that way. Okay, so finally let's take a look at eye development. This also begins in the 4th week, and this is really just a continuation of the neurulation process we saw with the brain. And one thing I like to point out is that the eyes are really just an extension of the brain tissue, and they sort of undergo their own little neurulation process. And what we see is these optic grooves are going to bulge out from the distal portion of the rostral neurotube, and then they're going to kind of start expanding. And as they do this, their connection to the neural tube is going to start getting thinner and thinner and create that optic stalk, which is your primordial optic nerve. Additionally, once these get kind of outpouched and become their own little circular spheres of neurotissue, we refer to them as optic vesicles. And then they're going to start creating this lens pit. And what happens is there's overlying specialized ectoderm tissue that's going to create our primordial lens and start forcing the optic vesicles to bend inward, as you can see from our diagram here. And then that ectoderm tissue is going to pinch off and create our lens vesicle as our eye basically invaginates and eventually encircles that region to form our primordial eyes. So relatively straightforward, just a lot of expanding and folding. But again, keep in mind that the interesting part of this is that the eye development is really just an extension of brain development, so it's kind of one and the same. So now let's go ahead and get into the nuts and bolts of the actual brain. We can take a look at the anatomy and histology here. And just to kind of give a primer, here's an fMRI I recently took of my brain, so you can kind of see what's going on in my head there. So let's get into just the anatomy and histology of the brain. So what we see here is a really big breakdown of all the different components of the brain that can be identified. All those sulci and gyri, and the sulci are going to be that space, and the gyri are the folded regions of brain tissue, can pretty much be identified on the brain, and you guys will be held accountable for that in neuroscience. And then when you take a cross section like this on the midpoint, again, you can start naming the individual gyri and sulci. So there's a lot going on. I don't expect you to kind of know those parts, but that's just sort of the big picture of what you could identify, and something to look forward to, I suppose, when you get into the spring quarter. However, I do just want to point out, I always like the side view of the brain. It kind of looks like an old man with this like little mouth hanging down, or sometimes I like to think of a little evil scientist hanging in there and controlling your body. But that's really just the basics of the brain. The stuff I want you to take away from this lecture are really the stuff you learned in anatomy this year. You should be aware of the lobes and kind of their various roles in the body. And the only sulci and gyri I really want you to know, there's the central sulcus, which divides the frontal lobe from the parietal lobe. and then the precentral and postcentral gyri that are going to be on either side of that. So your major lobes to be mindful of are the frontal, parietal, temporal, and occipital. And again, we'll look at those functions when we get a little bit later. But just a basic review is frontal lobe is going to pretty much be your personality, sort of your higher decision-making functions. Parietal lobe is going to be that proprioception, kind of your feeling of the difference between you and the environment, being able to navigate around the world. Temporal lobe is really just kind of your spatial awareness in the sense of kind of like keeping you conscious and your understanding of language and understanding of your environment, sort of the interpretation center. Your occipital lobe is really going to be your visual cortex. Additionally, on the outside, we can see our cerebellum, medulla oblongata, and pons. Those are kind of prominent features on the hindbrain there. Let's go ahead and take a cut on the midsection here. So if we do a mid-sagittal cut, some of the structures you should be mindful of are the whole thalamic region, so that's diencephalon. And so you have your hypothalamus, thalamus, and your epithalamus, which is also known as your pineal gland. Over here I have superior colliculi and inferior colliculi. That stuff, those are more involved with your visual cortex, and we don't really need to stress those out here. You can be mindful of that, and we'll get into them a little bit later. Or actually, you'll get into them a little bit later when you cover them in neuroscience. So here you can also see the midbrain for functions and the rest of their hindbrain, as well as the pituitary gland, which is our primary endocrine gland in the brain. And we can get pathologies of the endocrine glands as well. So just be mindful of the stuff that's labeled here for the most part. Additionally, I want you to be mindful of and be able to identify your ventricular system. So you should be able to identify the lateral ventricles in the cerebral hemisphere, the third ventricle kind of locked in the thalamus, that cerebral aqueduct that leads from the third to the fourth, and that fourth ventricle located anterior to the cerebellum as well. And those are all going to eventually leak out from their cisterns into the surrounding cerebral the arachnoid system there, and then eventually make its way back into the sinuses. So on the cross section, I want you to be able to identify some of the structures here. Basically, first you should be able to see the difference between gray matter and white matter. And now it's really nice and easy in the brain because the white matter is essentially located and it's very white. So those are where all our axons are, and that's basically the white part is indicative of our myelinated sheaths that are wrapping those axons of the neurons. And the neurons are housed in the gray matter, and that's going to be located on the periphery of the brain. So everywhere you see that kind of beige color, it's technically gray matter. Now, this gets flipped when we get to the spinal cord, and the gray matter is going to be centrally located as the axons are going to divide out into the gray matter, from the gray matter into the surrounding white matter, and then eventually make those peripheral nerves. So you should be able to identify those components. Additionally, I want you to know the basal ganglia components. We see a couple labeled here. The one we don't see, which is probably also equally important, probably most important, especially for pathology, is the substantia nigra located in the midbrain. But here you can at least see our globus pallidus. You can see our putamen nucleus, or they don't have it labeled as putamen nucleus. But if you think of the basal ganglia as kind of this outside triangle here within the white matter, the putamen is going to be this one located on the outer portion, and the globus pallidus is located on the inner portion. So those basal ganglia are important because they help control a lot of fine motor movements, and pathology is located in that. We can get infarcts and we can get neurodegenerative disorders will ultimately affect kind of your ability to control your muscle movements. Additionally, the hippocampus, you should be able to identify. It's this sort of curly Q, cinnamon roll looking thing in the amygdala region, and it's going to be located next to our mammillary bodies. And that becomes important when we start doing whole brain cutting, which we'll talk about in surgical pathology later in this lecture. But these are sort of the main points that I want you to look at on a cross-section of the brain. Now you could cross-section the brain from anterior and posterior, and there's a lot of other various components worth identifying. But again, for purposes of surg path, let's just stick to the basics here. And then of course we want to look at the vasculature of the brain, particularly the circle of Willis and the structures or in the posterior structures as well. The other key takeaway here is the dual circulation of the brain. So we have our vertebral arteries on the posterior side, which are going to converge to our basilar artery, and then we have our internal carotid, which is going to supply sort of the anterior aspect. Now, the internal carotid comes from our common carotid, which is tends to be one of the earlier branches off of the aorta and subclavians respectively. But we also get the vertebral arteries, which are coming off our subclavian artery. And so this helps create a redundancy in circulation in the brain, which is really helpful because the brain requires a lot of oxygen. It's going to need a lot of nutrients, and we want to make sure that it doesn't get easily impeded by a single blockage. And that dual circulation helps with that. So really this should be the takeaway from vasculature. You should be comfortable with knowing where the posterior posterior circulation starts, mainly the basilar artery coming from the vertebral arteries, and that's going to be located on the anterior aspect of our brainstem. And then the circle of Willis, which is made up of our posterior cerebral, middle cerebral, and anterior cerebral arteries, as well as their communicating vessels there. So just notice the anterior communicating vessel is the only vessel that connects, or basically it only connects the anterior cerebral, where our posterior communicating really connects our posterior cerebral to our middle cerebral or internal carotid. Another interesting note is when we deal with strokes, because the internal carotid kind of just gives rise to the middle cerebral, we do tend to see a lot of our strokes and emboli occurring as a result of obstruction of the middle cerebral artery. So that's definitely clinically significant, and another reason why the circle of Willis is worth knowing. As far as the cerebellar blood supply, you should be comfortable with the posterior and anterior inferior cerebral, so they're AICA and PICA. They're just kind of fun to say, especially in the abbreviated form, but those are the primary blood supplies for your cerebellum. But all these other smaller vessels that you see in the previous slide, I'm not too worried about. Again, you'll get in a little more detail of those with neuroscience, but they're not as significant when we're dealing with the basic surge path components. So let's go ahead and look at the histology of the nervous system and the main cells we see. And there are two primary cell types that you're going to be dealing with. The first is neurons. See, without neurons, we really don't have any neural function, and these are the functional cells of the nervous system. These are what are going to relay our action potentials from one area to the next, which is going to be whether it's in the brain itself, from the brain to the spinal cord, or from the spinal cord to the rest of the body. So neurons are important for that regard. And then you're also going to have neuroglial cells, and these are kind of supportive cells that you'll find in the rest of the central nervous system. And most of those are going to be astrocytes. They make up a bulk of our supportive cells. And these really take the place of what we saw the mesenchymal cells do in the rest of the body. Now, the brain doesn't have that similar connective tissue buildup that we see everywhere else. We don't have loose and dense connective tissue holding everything together. Instead, we have astrocytes kind of creating this network and webbing of material to house all our neurons and remaining supportive cells. And so that becomes important because without the astrocytes don't serve the same function. They don't lay down fibrous tissue. They don't create scars like we see in the rest of the body with all those supporting cells. So instead, when there's an injury to the brain's going to undergo liquefactive necrosis, which means once those cell and tissue areas die, they don't repair. We don't get scars like we see when heart tissue dies, and you get a nice firm fibrotic scarring. And so we instead see cavities build up in the brain itself. Next, you'll have ependymal cells, which are going to be these specialized epithelium lining ventricles and spinal cord columns. And these you can kind of think of as like duct cells. And they're cuboidal, so they have a similar appearance than the ones you see in these interlobular ducts and intralobular ducts. And some of these will be specialized to create cerebrospinal fluid. And then you also get oligodendrocytes, and these are going to be the myelin-producing cells for the neurons. These are known as Schwann cells in the peripheral nervous system, but they're unique special cells in the central nervous system that are going to produce this myelin. And these are interesting because they have a nice little fried egg appearance, and so when we see tumors of this, they kind of have that like smear of fried egg cells all over the place. And the final supporting cell to be mindful of is this microglia, which is basically the macrophage of the CNS. So again, they have their own specialized immune cells to respond to any sort of infectious agents. So here's kind of a look. You can picture all the various cells. Over here in the specialized staining region, we have a neuron, and you can see the dendrites extending off of that. And we'd actually see an axon depending on what plane we come in, which is going to be a longer cell component. Down here we have our ventricular system, so these cuboidal cells here are going to be our ependymal cells, and then you have that astrocyte laying, not really a basement layer, but sort of this support network underneath. And then in the far image over there, you can see the neurons labeled with the N, so I'll get the pointer out if that works. So we got these neurons, and the thing to keep in mind is these oligodendrocytes are going to be hugging these neurons, and they're going to try to be producing that myelin sheath around it. And so when you're trying to find these histologically, you usually want to try to find them close together. Whereas astrocytes can tend to be sort of spread out throughout, because again, they're creating that support network for the cell. The one we don't see in here is microglia. But again, you can just think of those as being a specialized form of a macrophage, so just look at those big white cell looking structures. So now we covered the basic structure and function of the brain. We can get into the brain pathology, and that's kind of the meat of this lecture. Before we get into some of the specific pathologies of the brain, there's some general concerns I want to go over that are very unique to the location of the brain that we don't see in the rest of the body. And that's primarily because the brain is very locked into this nice, well-formed environment that doesn't adapt well to changes. Now, when we see pathologies developing in the rest of the body, usually the body can kind of just work around it and deal with it. And sometimes these pathologies or tumors can grow, especially in the abdomen, without a lot of awareness by the patient until they become very large. However, in the brain, very small changes can be very noticeable quickly. And so even benign conditions can cause very life-threatening conditions down the road if not addressed and handled immediately. So what this is known as mass effect. So very small changes in mass are going to shift the brain around, and we don't want the brain to shift. Everything is kind of nice and organized and in space, and you can think of the brain as being very OCD in that regards, and so when you start moving around its things, it gets really pissed off, and that's not what we want. And so we'll look at things like herniations, as well as disruptions in blood supply and how those will factor in. The other thing to keep in mind, though, because of the location of the brain, I guess one benefit we can call it, or quote-unquote benefit, is that the brain tumors don't usually metastasize. So our malignant tumors tend to stay localized in the brain. Now, they're still problematic, and because of that mass effect, it's probably even worse than tumors in the other area, but a lot of tumors will metastasize to the brain, but that doesn't happen in reverse as often. So the first thing we'll look at is edema. So any sort of trauma or disruption in the brain environment can ultimately lead to edema. So infections, inflammations, any disruption in the blood-brain barrier, try saying that 3 times fast, can cause an increase in permeability. And we see edema in the rest of the body, and usually the body's fine with it. Sometimes you see swelling in the arms or legs, especially if there's inflammation or affecting any sort of pathologies affecting lymphatics. And the body, again, can handle that, and usually by compression or massaging, or even if it's just in the abdominal structures, it just sort of absorbs it. We don't have an issue. But what we see in the brain, that is a whole new ballgame. So looking at these images here, the one on the far left is actually an image of a normal brain. You can see these well-demarcated sulci and gyri of the brain. But now we look at this one with edema here on the right. We can see that the gyri are quite swollen to the point where we really can't even identify any sulci in them. And what this is going to do is increase the overall volume of the brain. And again, we get into that mass effect where now we're going to start seeing things like herniation. Or we might see disruption of blood vessels because now they're being pinched or contorted in ways they were not meant to go. So edema can be a very serious concern, and it's harder to treat in the brain than it is in the rest of the body. And so you got to be mindful of infections in the brain for that reason. So speaking of herniations, what we're worried about here is shifts of the brain from one section to another. And when we talk about sections, we have to remember that in anatomy, we learned that there are many dural reflections in the brain. And then these serve multiple functions. One is that they help create these sinuses that blood is going to ultimately drain into so that it can return to the jugular system. but also they kind of separate specific areas of the brain. So we have our superior sagittal sinus, for instance, which is going to separate our left and right hemispheres of our cerebrum. And then the one we're worried about here is our transtentorium cerebellum, which is going to be a dural reflection that actually is dividing the cerebrum from the cerebellum and the posterior aspect there. And what can happen with that is if we get any sort of mass or disruption in the upper hemispheres, so maybe our cerebrum on either side, that can start to push brain tissue through that tentorium and will ultimately lead it to pinch off. Those tentoriums are very rigid and they're very hard to disrupt. Even when you're doing this in autopsy, they're very hard to cut, and you have to kind of work out the kinks and basically trying to remove brains without totally disrupting them and knowing how to cut these dural reflections. So they're not going anywhere. Instead, the brain's just going to work around that. Now, pinching off brain tissue is never good, but what can be most problematic is in this particular region around that tentorium is we have our hippocampus and uncus that we looked at a little bit earlier. And what that could do is pinch the ocular motor nerve root just underneath it. And ultimately what that can do is lead to droopy eyes, fixed pupils that are dilated. And that's going to happen in the same size. So if you're doing a neurological exam, you can kind of see if someone's suffering from this ocular motor nerve palsy, which could be a result of maybe something neurological, a direct insult to that ocular motor nerve, or there's a good chance that it is a result of a herniation, and that might speak to something else going on in the brain, whether that's just some sort of inflammation, or maybe there's a mass in the upper hemispheres that could be pushing this tissue down through that tentorium. One of the worst ones, though, is this cerebral tonsillar herniation. And these usually occur with some sort of disruption or mass or growth occurring in the posterior fossa or the skull base. And the skull base we'll see repeatedly. These tumors or anything in the posterior fossa tends to be the most problematic. When we talk about posterior fossa, we're really just talking about everything kind of in the back of the skull here on the inferior aspect. And the reason why is that stuff's hard to get at surgically, and those growths are often closer to things that are more pertinent to life-sustaining functions. And particularly when we look at these cerebral tonsillar herniations, we're worried about these masses pushing our brainstem through the foramen magnum. And what that can do is potentially crush or impede our medulla oblongata, which is very important in sustaining life, particularly with respiratory function. And so we can either get immediate respiratory failure, or ultimately this could lead to death in the patient if long-standing or very severe herniation has occurred. Additionally, we're worried about any sort of vascular change. So typically our blood supply in the brain, all those vessels we looked at, the arterial supply, likes to remain where it is. But when everything's shifting around and contorting and twisting and getting pinched off, ultimately it could lead to an impacting on the vasculature in that particular area. And what we see in this particular region is what's known as a direct hemorrhage, or anything on the pontine region. So usually your basilar artery might be shifted, and that could be a result of maybe a tonsillar herniation. Also, we'll see this in any sort of swelling as well, as the brain just kind of expands upon itself. So these are some secondary concerns as well from masses. So if we look at something like a meningioma, which is normally a benign tumor, depending on where that goes, we may see consequences like a herniation or a ruptured blood vessel, and those have to ultimately be addressed as well, rather than just getting the tumor out. So now we can get into some of the specific pathologies of the brain, and I broke these down into non-tumor or relatively benign, put the air quotes up there, benign, because we just saw that benign stuff is not always benign, and then we classify the others as tumor-based, so any sort of abnormal growth. So let's go ahead and start with the non-tumor type stuff. So the first thing we can point out is traumas, particularly epidural and subdural hematomas, but any sort of trauma can occur in the skull region. So whether it's just a fractured skull, and we talked about that a little bit in anatomy, or any sort of hemorrhaging of material like those Durant hemorrhages from maybe some twisting and contorting, or someone gets in a car accident and there's just some bruising in the brain because of counter-coup injury, any of that could result in problems. But the ones we most likely will see in surgical pathology are associated with an epidural or subdural hematoma. Now the epidurals are arterial hematomas, and what that means is usually it's a rupture of some sort of arterial supply. Most likely it's going to be your middle meningeal. As you recall from anatomy, in that temporal fossa we have that prion, which is sort of the four corners of your skull. And what that is going to house is just behind that is your middle meningeal artery. And that region is relatively thin and prone to getting fractured, and if it does, there's a high risk that your middle meningeal artery is going to get ruptured. Now, if that's the case, that is outside your meninges and completely outside your dura of the brain. And so what happens is this blood starts pooling and pooling and pooling and creates this hematoma or blood clot, or actually translates to blood tumor. So that's going to keep growing and pushing your dura away from the skull towards the brain. And so we're worried about those mass effect issues we just talked about, but we're also worried about the fact that you are losing blood, and quite rapidly. So what we'll see is these individuals will get rapid onsets of maybe headaches, loss of consciousness, relatively periodic lucid periods, and this has to be addressed right away, or else the patient will ultimately succumb to the loss of blood. And that's ultimately what will kill them, not necessarily the mass effects, although those could also be problematic depending on where the hemorrhage is. And we contrast that to subdural hematomas, and these are hematomas as a result of venous disruption. And so these are not going to occur outside the dura, they're actually going to occur between the dura and the arachnoid. And we have these bridging veins between the sinuses and our skull that as we continue to get older, our brains are actually going to shrink and get smaller in density and size. And what that means is we're more prone as we kind of get in accidents or fall downstairs as we do. We might actually shake the brain enough where those vessels are going to rupture. And what's going to happen is once those vessels rupture, they're going to be able to start filling the space between that dura and that arachnoid space, or just the arachnoid matter. And as you can see, this is going to be slow growing. These symptoms tend to evolve over time. And the difference is in CT scan is usually our epidural hematomas are going to be very localized into a small region because that dura is going to be tightly adhesive to the skull, whereas our subdural hematomas tend to spread diffusely between our dura and arachnoid matter. So you'll see that kind of spread out a little bit more. And that tends to be a classical representation of a subdural hematoma. And these also need to be treated relatively rapidly because you're still losing blood. And again, we're worried about some of those mass effect issues of herniations and potential other vessel ruptures. Along the lines of vascular injury, we also can talk about cerebral vascular disease. And this is usually a result of some sort of injury or disruption of blood flow to the brain. And ultimately, we refer to that as a stroke. Now, there's two types of strokes. Or two divisions. We can either have a global ischemia or a focal ischemia. And global ischemia is going to be some sort of systemic disease typically. So we see an overall loss of perfusion in the blood supply to the brain. And this could be resulted from atherosclerosis or some sort of other hypoperfusion of blood, such as maybe blood loss somewhere else. But then that is noticed because you see both hemispheres kind of affected relatively equally. Compare that to focal ischemia. This is usually a result of some sort of infarct or emboli lodging in that middle cerebral artery. And what you usually see is just one side, one specific region is affected. And usually we talk about that being the watershed areas. So if you think about the brain on the outside, we have our anterior cerebral taking care of the front side, our middle cerebral coming up on the lateral side. And the areas where they kind of meet, or the blood supplies typically meet, is going to be our watershed areas. And those tend to be the most likely to be affected by any sort of loss of blood supply or disruption like an emboli, because those are the last places to receive blood. And so usually you see the infarcts, which these areas kind of match that watershed area. Now we can either get a lack of blood perfusion or we can get a disruption of blood vessels. So we can talk about these infarcts as being a hemorrhagic infarct or an ischemic infarct. Ischemic meaning a loss of supply, hemorrhagic meaning basically that the blood vessel ruptured. And the problem with that is if the blood vessel ruptured, it can't just distribute its oxygen appropriately. So we still see the symptoms of a stroke manifest. And that can be due to maybe a Barry aneurysm or any sort of aneurysm in the brain disrupting, or if that, we'll also see things like infarcts with hypertension that can result from arterioles disrupting. But either way, this is a great example of what liquefactive necrosis would look like. And ideally, well, maybe not ideally, but if this were to heal down the bottom, so you see this hemorrhagic infarct down here, it would be the same thing. So that tissue around that region where the infarct was would still die off, but this is probably incompatible with life. I'm going to go ahead and guess on that one, just due to the extension of the hemorrhagic disease. A couple of specific infarcts to be mindful of are these lacunar infarcts and these slit hemorrhages. And these are due to hypertension. Lacunar infarcts are going to be made up of these little lacunae, which means little lakes. And you'll see those located in the basal ganglia. And you can kind of see in this region here a bigger area. But a lot of times what you see is these little petechial hemorrhagings throughout the basal ganglia. And it just doesn't look smooth. It looks like someone took a needle and just started poking in the basal ganglia. And those are basically an indication of lacunar infarct. So oftentimes you'll see those as autopsy findings. And you can kind of surmise that the patient likely had hypertension and likely had a long-standing atherosclerotic disease. And what's going on is these little arterioles in the basal ganglia are basically suffering and being blocked off and preventing blood supply from getting into that particular region. And so those tissues just die off. Contrary to that, those arterioles can also rupture, and when they do, they create these slip hemorrhages. And these are smaller hemorrhages that will likely heal. They occur around the midpoint of the brain, particularly that central basal ganglia region. But ultimately, once they hemorrhage, they'll heal up, and you get these little slits that you can also find during autopsy. So depending on the degree of these are usually pretty compatible with life, but you might start seeing symptoms like people with long-standing hypertension. If their basal ganglia is getting disrupted, they may have difficulty controlling their motor movements regularly. So they might just be a little more clumsy and things like that. Or you can kind of see some effects that you would see like in Parkinson's, where you kind of just have this like jittery motion with your hands or legs and things like that. It's harder to control just a nice, nice fine reform movement like we normally can do. So the brain is prone to infections. I'm not going to be harping on these two particularly. Just be mindful of the various infections that you can get, and basically any type of infection such as bacterial, viral, fungal, or protozoan. A couple of ones that I do want to just kind of discuss from this extensive list is things like mucormycosis and toxoplasmosis. I find these kind of interesting. So mucor is something that you might experience in surge path. As far as like wanting to do frozen sections. So I remember getting frozen sections on these. It's like, what's mucor? And what this is a function or a fungal infection that you usually might see in the nasal cavity. And so they'll do frozens because they want to try to find a place where they can stop it that's not infected, because ideally they can resect that and prevent the fungus from actually reaching the brain, because once it does that, it can be fatal. So you might be part of these frozen sections where they're looking for mucor, and basically they want to try to find these hyphae fungal components that they can say are present or not present. And then things like cerebral toxoplasmosis, and even these cerebral amoebas that can be found. Protozoans are actually quite interesting, I think. What you can see with toxoplasmosis is a relatively common infection. This is the one that's associated with Toxoplasma gondii is the infectious agent, and that tends to be housed in cat intestines, and that's why we see cat litter boxes tend to be a common source for these. So pregnant women are often discouraged from changing cat litter boxes because they become more prone to this, and toxoplasmosis can be transferred to an unborn child and give you torch syndrome. But what's interesting is they've done studies on these, and like some of these protozoans, particularly Toxoplasma gondii, people that are infected with it have shown subtle changes in behavior. Men tend to be a little more aggressive, and females tend to be a little more promiscuous. Now it's kind of it's not been It's not been completely like validated studies, but there's just kind of some interesting correlations that these Toxoplasma can alter our personalities. And if you ask me, I think that's the way that zombie virus is going to form, with some sort of protozoan that takes over our mind. And then these cerebral amoebas, these are things that are found in dirty water supplies. And there's been a couple of cases. I remember I had an autopsy on someone who had this, a very young person. They were in their 20s, and they just ended up dying because this amoeba just gets into their brain. And the way that happens is either if you're swimming in dirty water, pond water, lakes, things like that. Another common way is for people who use neti pots. If they don't properly sterilize the water or boil the water, and they're putting that up their nose. Basically what happens is that nose, if you remember from anatomy, is our little danger triangle, because infections can easily get into the brain from that area. so that they just go retrograde towards the brain, is a very easy communication between that and some of our sinuses in that region. And those protozoan, those amoebas from that dirty water, if you jump in that dirty water and it goes right up your nose and they lodge there, they can find their way into your sinus supply and basically just infect your brain from there. And the same with those neti pots. If you're basically just giving them open door access to your nasal cavity, they'll get themselves in there, and then they'll start, killing away. So very dangerous, and these things are scary because you don't see them, and if you're like me now, you're afraid to jump in any sort of dirty water, or at least hold your nose when you go in there. So a relatively rare occurrence, to be sure, but it's something to be mindful of, especially if you use neti pots quite regularly or you find yourself diving into swampy waters. Now, the one infection that I do like to talk about, and I think you should be accountable for, is these prion diseases. I find these absolutely fascinating, if not downright terrifying. Now, infectious agents are usually considered alive. Well, they are considered alive. But in the case of these, this is just an unfolded or a misfolded protein conglomerate that can somehow reproduce itself and becomes infectious to neural tissue. And so these proteins basically just keep being passed along, but they're not alive. It's literally just protein. And this can be something that's either familial, so you can get it from genetics, or it can be sporadic that you get from your environment. But what happens is these prions start embedding themselves in the neural tissue, and you get what's known as spongiform encephalopathy. So you can see these vacuoles in our brain tissue here from this prion disease. And that ultimately leads to rapid neurodegeneration, usually within a year, until the patient finally expires. The most common one that you'll hear of or be referenced to, or you might even be exposed to autopsies for, is Creutzfeldt-Jakob disease. So typically, if you do get these for an autopsy, they're going to be sent to specialized locations that can handle these. These prions are very infectious and they're very hard to kill, and they usually don't want to do that in just a standard autopsy or autopsy suite or hospital setting. If your hospital happens to be one of those centralized locations, a lot of times one person is going to be kind of the go-to person for that, and they're going to gown up and get completely protected. The only thing that really kills these, they don't die in formalin, and autoclaving doesn't necessarily work. So usually you just need some sort of formic acid concoction that's going to break down that protein structure and kill it. But here again, like I said, these I find fascinating. Here's a couple of articles about it. So the first one basically just describes how now they've been able to find that protein or prion diseases can transfer and be found in eye tissue. So if you're having eye surgery, you have to be cognizant of the fact that maybe if you're doing the eye surgery, you want to make sure you clear your tools effectively. Or if you're getting it, you just want to make sure that the surgeon is clearing the tools effectively, because the second article is actually something that was in 2013. It's this neurosurgeon back in New England area, and they ended up infecting several people with the prion disease because their tools were infected from each patient. And even though they go through the normal sterilization process between patients, that's not enough to kill prion disease. So these patients were literally just given prion disease because they went in for a brain surgery, and maybe it was as simple as a biopsy in some of these cases. So take a look at those when you get a chance, and just get yourself scared and freaked out for prion diseases like me. So next up, let's take a look at demyelinating diseases. Most particularly multiple sclerosis tends to be the most common, which is an autoimmune disorder. And what this does is actually affect and destroy the myelin surrounding the neurons. And so you can actually see a really classic example of this. So note, if you remember from our earlier images, that central portion of the brain should be white, consistent with that white matter, which is made up of the axons covered by that myelin. Well, once that myelin is deteriorated, we don't see that classic white looking appearance. Instead, we see this sort of tan brown look. So this is something to look for on autopsy, or at autopsy. If you see sort of a discoloration of the central portion of the brain or that white matter area, you should be thinking that there's likely a demyelinating disease. And in multiple sclerosis, usually what happens is the disease will come back and go away periodically. But ultimately what will happen is that myelin gets destroyed, and eventually those nerves are going to kind of become less functional. The neurons are still there, but we start losing sensation. The sensations between those neurons doesn't travel as effectively. You start having vision problems. A patient will experience numbness or lack of feeling, fatigue, or general just mobility issues associated with that. And unfortunately, being an autoimmune disorder, it's harder to fix, and usually don't detect it until the patient is a young adult. But again, a very classic example on the image here. So contrast that to neurodegenerative disorders, which actually target the neurons instead of just the myelin. And these are usually a result of an accumulation of protein aggregates in the brain tissue. And they've actually done studies to show that sleep helps sort of minimize the accumulation of these protein aggregates, because when we're sleeping, our brain shrinks just a little bit to allow some of that the fluid to kind of spread through our general areas and wash clean any of the excess proteins that we don't need. It's sort of like a giant lymph system of just washing the bad stuff away. So if you're not getting enough sleep, they've actually shown that increases the likelihood that you'll have some sort of dementia later in life due to the accumulation of proteins. So knowing how bad I am at sleep, this is probably something I have to be mindful of if it hasn't already started occurring. But the two that we'll look at are Alzheimer's disease and Parkinson's disease. Alzheimer's is the most common, and usually this is going to be just an incidence of age, which means the older we get, the more likely we're going to get this disease. And theoretically, if we all lived forever, we're eventually going to get Alzheimer's disease. No matter how much sleep you get, it'll eventually just start accumulating. That's just the way it is. And what happens is these amyloid plaques and these tau tangles are actually going to start building up and start creating this sort of bridge gap of memory deficits and eventually leading to a lack of function of these neurons. Now, they have shown that certain light frequencies in mice have been able to sort of reverse the effects of Alzheimer's. And it basically shows that we don't lose the memories, we don't lose the neurons, we just lose the ability for those neurons to communicate with themselves, and those memories become blocked off. But it's really kind of a detrimental disease to watch, because people just eventually deteriorate into a childlike function and become forgetful of just about the basic functions of life. So looking at some of the findings for Alzheimer's disease, we can see a normal brain autopsy on the left and contrasted to an Alzheimer's brain on the right. And the thing that should stand out are these gyri are kind of more shriveled up, but we really see prominent sulci in the brain. And that tends to be a very classic finding, that if you open up a patient during autopsy and you see these really prominent sulci crevices, there's a high chance that they have some sort of Alzheimer's disease or maybe just a regular neurodegenerative disorder, because we're starting to lose function of that brain. But here you can see the amyloid plaque buildups in the neurotangular fibers that are going to help be diagnostic for that particular disease as well. Next is Parkinson's disease, which is going to be a result of these loss of dopaminergic neurons in the substantia nigra, which is located in the midbrain. And the substantia nigra is part of our basal ganglia. So if you remember when we were talking about the lacunar infarcts in the basal ganglia and the impact those would have, we'll see very similar things, if not more prominent, in Parkinson's disease, because all of the neurons are being impacted, and or particularly all the ones in the substantia nigra. And so what these tend to show is patients will have this pill roller symptom, and their hands will just kind of keep moving, or their movements are going to be overall hypokinetic, which means very slow and methodical. So they really just have a loss of that fine control, and it's harder to do things like hold pens and pick up objects. So we'll also look for Lewy bodies histologically, which tends to be pathognomonic for these diseases. So here you can see a Lewy body over here on the far right, and they're kind of nice little inclusion bodies there. So once you see those, you should be thinking Parkinson's on histo. But grossly, we have a very prominent pathognomonic finding, which is the difference between the coloration of the substantia nigra. So on the far left, you see normal substantia nigra. It's got this brownish color, but the one on the right is very pale to the point of not being colorized at all. And if you see that when you're cutting, and that's why when we're doing brain cuts, you want to make sure you're cutting through the substantia nigra, particularly the midbrain, so that you can see that region. And if you're not sure, if you think you missed it, just keep cutting around that area just to make sure you can validate that there really is no coloring present. But again, that's basically those loss of those neurons in that basal ganglia, and we start losing the function of that completely. So that's something to look for during autopsy as well. So that about covers the non-tumor pathologies that we'll look at for the brain, and we can start evolving into the brain tumor aspect. And before we do that, I want to look at the epidemiology and sort of the incidence of brain tumors in the population, particularly in the United States. Now, overall, brain tumors are not that common, and if we look at the SEER data, and one thing I should probably note is that our SEER data is really an accumulation of all brain and other nervous system cancers, so we can't really attribute it to a particular cancer type and its occurrence. But overall, if we're dealing with these neurological tumor cases, it still gives us a good picture. So one of the things that stands out is like brain tumors are not that common. They're relatively low on the order or hierarchy of cancers here, ranking number 16, and overall 1.3% of all new cancer cases. So that's relatively low. But the one thing I will draw your attention to is the number of deaths compared to the new cases. So if our number of new cases is about 24,000 and our deaths from those cases about 18,000, we're looking at about 75% death rate for the occurrence of these cancers. So that's kind of problematic. And so even though you don't get these tumors often, when you do get them, they're pretty serious. And that could be a result of just the tumor itself, or again, some of those general concerns like the mass effects with herniations and vascular ruptures. So again, looking at the numbers, 1.3% of the new cases, but almost double up the percentage for cancer deaths in this case. So definitely more deaths rising from brain tumors than actually occurring. And we look at a 5-year survival rate of 32%. We do tend to see these cancers more common in males than females, although females tend to get meningiomas more commonly. So usually your classic patient for like a GBM, which is your most malignant brain tumor, is going to be an older male, usually in his late 50s and early 60s. And that will be kind of the demographic we're looking for there. But a couple of other basic stats to be mindful of. Median age of diagnosis and death is 59 and 66 respectively. This is in older adults, or I should say middle-aged adults. It's the second leading cause of deaths for males, and that's only second by after leukemia. And one thing to point out is actually the most common brain tumor, we're not talking primary brain tumor, the most common brain tumor is actually metastatic disease. In children, brain tumors are the most common tumor a child will get, but they're overall relatively rare. So brain tumors account for 20% of all childhood tumors. And for the most part, children can be really resilient to some of these tumors, and they can be quite amenable to treatment. However, for children, these are the second leading cause of death, again, after leukemia for individuals under 20. So they're definitely a serious problem, and a lot of that is not only just the fact that the tumor could be potentially malignant, but the location is just really hard to work with. We can't just go out resecting brain tissue willy-nilly. But the types of tumors that we'll look at here, the two I want to kind of point out are meningiomas and glioblastomas. These are just some stats that you can kind of work through. But the most common primary brain tumors, so even though metastatic disease is the most common tumor, when we talk about primary brain tumors, we want to talk about tumors that are arising in the brain tissue itself. And meningiomas are the most common. And the nice thing about that is they're typically benign, but we'll talk about those in a little bit. On the other hand, glioblastomas are the most common malignant tumor, and that's a class of a glioma. And the gliomas tend to represent the most common groups of tumors, and most gliomas tend to be malignant and very problematic. So gliomas are really just a class of those glial cells, and we'll again look at that classification shortly. So some of these other ones, it's not really important to matter, but you can just see the overall occurrence incidence of some of these tumors. Now, again, a breakdown of age. Like I mentioned, glioblastomas tend to be found in patients in late 50s, 60s, and even 70s. What's interesting to note too is meningiomas kind of have a double occurrence rate, and these tend to be more likely found in females than males. But we see that happening kind of in late middle life to late life, I guess you would call it. I don't know what the exact breakdown for those age groups would be, but just something to be mindful of and some fun statistics. As far as risk factors go, there's really no risk factor that's going to account for a majority of brain tumors. And the problem is there's just so many things that could form tumors in the brain that's really hard to account for all of them. And so it's really difficult, whereas other tumors you can just, avoid cause X, Y, and Z, and you're usually pretty safe from those tumors. Brain tumors don't really have that per se, so you have to just kind of be mindful overall. But some of the things could be environmental or genetic factors. Environmentally speaking, food with nitrites, head injuries could ultimately cause it because of the healing response needed for these brain tumors. And pollution, ionizing radiation, and formaldehyde. It's a good thing we're not ever working with formaldehyde, right? But you should be relatively safe if you're not chronically exposed to these things. In regards to ionizing radiation, one thing I will point out, because I'm sure this comes up and you guys might hear things, so it's good to kind of have a working knowledge of it, but cell phones don't emit ionizing radiation. They are non-ionizing radiation. But there is no direct correlation between cell phone use and brain tumors, although there's also no definitive no connection, if that makes sense. So what had been expected is with the increase of cell phone use over the last 2 decades, there should have been a correlating increase in brain tumors, which there hasn't been. So while it can't be 100% ruled out, the chances are that it's non-existent as far as a link to brain tumors. And I maintain the camp that cell phone use just doesn't cause brain tumors unless there's some sort of secondary factor involved there. So go ahead and use away, but I think cell phone usage should be restricted completely to texting and phone calls. No bueno. Genetics also play a role. So TP53 you'll see make a prominent occurrence in a lot of tumor growth. And anytime we get a mutation in a tumor suppression gene, it just allows the tumors to continue to grow. Additionally, EGFR is another one that can be prominent in a lot of tumor development. But what is interesting and something you should be mindful of is some of these chromosomal links. And because they are documented, I think it's worth knowing that oligodendrogliomas are linked to 1 in 19 mutations, glioblastomas to 12, and then meningiomas are linked to mutations in chromosome 22. So because those kind of have direct tie-ins, we could probably relate those to genetic disorders and mutations that could be theoretically tracked initially. So when we start breaking down the different types of tumors, we'll start with gliomas, which is the most common group of tumors. And if you remember, glial cells pretty much make up all the supporting cells for the nervous system. So we had glial cells and we had neurons. So anything that was in that glial cell group could theoretically become a tumor. So this is all the supportive cells, all those ventricle lining cells, all those myelinating producing cells can ultimately lead to tumors. And because of the vast majority of these cell types present in the brain, it makes sense that they're the most common group. The one we'll talk about most is astrocytomas, because astrocytomas tend to make the highest presence of these tumors and are also the most likely to be malignant. So astrocytomas will be broken up into different types depending on essentially their grade and stage effects and the overall appearance. So we'll break this down into a localized versus an infiltrating type. So localized tend to be a little more amenable to treatment. And the one classic example is the spilocytic astrocytoma, which is usually found in younger individuals, particularly children. And these tend to be well circumscribed with some cystic formation. So usually you can go in and treat it, and I think they're responsive to radiotherapy as well. But this is your most common localized astrocytoma. And so localized means good. It's like going to be localized to a specific area, and you can pretty much easily demarcate where the brain stops and the tumor begins for localized. Now contrast that with infiltrating. Well, infiltrating we know is bad and is really a classic sign for some type of malignancy. So the rest of the astrocytomas are going to be infiltrating astrocytomas, and those are definitely not favorable prognoses. Now, the one thing I will point out here, and we'll go into a little more detail, is the notion of grading in tumors. So the WHO, the World Health Organization, has a specific grading system for brain tumors that's different from the AJCC staging thing that you guys are used to. So we don't talk about it in terms of a tumor having a stage plus a grade. It's really like a grade that's all encompassing. So it's going to take into account the physical appearance of that tumor, the gross surroundings and everything that's involved, as well as the histological component. And that ultimately makes a grade 1 through 4, 4 being the highest grade. So what we'll also notice is that when you have a tumor identified, particularly like the individual named tumors here, it's really tied to a specific grade. So you can never see a diffuse astrocytoma as a grade 3, because it's automatically going to be a grade 2. And if we do change it to a grade 3, well, then it's an anaplastic astrocytoma. And we'll look at a chart at the end that's in the CAP protocol that makes that kind of more apparent. But the 3 types of infiltrating astrocytomas we'll look at, the most common of these infiltrating types are diffuse, or grade 2, anaplastic, which is grade 3, and glioblastoma, which is grade 4, the worst of the worst. And the breakdown of those is diffuse is going to be poorly defined and gray infiltrating borders, but we don't really get a lot of hemorrhaging, or it looks relatively okay. And anaplastic is going to be a little more on pleomorphism and maybe some mitotic features. You might see a little bit of hemorrhaging in there. And then you take that all the way to a glioblastoma, which is going to have necrosis and hemorrhaging throughout and highly infiltrative. So let's go ahead and take a look at some of the images for those, starting with the diffuse astrocytoma. So if you look at the CT scan and then the gross image over here, it looks, I mean, if that was found anywhere else, you'd consider that a benign tumor, right? It's really homogeneous. It's got semi-demarcated boundaries, but it is, especially as you get to the inferior aspect here, it's really difficult to see where our tumor stops and our tissue begins. So resection will be very difficult. But we don't usually resect these because if you don't get a positive or a clean margin, the tumor's just going to grow and you did a lot of damage for really no effect. And not to mention that you can't just take out parts of the brain without worrying about what the outcome for the patient would be. So these diffuse astrocytomas are in a grade 2, and you can kind of see how, okay, I can see why that would be a grade 2. We don't really see a lot of hemorrhaging. Now grade 3 astrocytoma, which is this anaplastic, now we got the cystic components as well, and you start seeing little areas of hemorrhaging and maybe potential necrosis. The CT scan doesn't look that great, right? And again, now you really can't tell the difference between brain tissue and tumor tissue. So that's when we start getting to grade 3, definitely non-resectable tumors. And then finally, glioblastomas. So these are the big bads of the brain tissue world. Glioblastomas are grade 4 astrocytomas, and hopefully by looking at it, that makes sense. You definitely can't see where the tumor ends and the tissue begins. Extensive amounts of necrosis and a hemorrhaging material. And CT imaging, what we get is this enhancing ring, which is a classic appearance of glioblastomas. So if you see that on imaging, that should be one of your first things to think about. And then if you're taking biopsies or getting samples, you'll notice this palisading ring around necrotic tissue is also characteristic of glioblastomas. So they'll either be called glioblastomas, grade 4 astrocytomas, GBMs, glioblastoma multiformes. There's really a multitude of names that are corresponding with these diseases, but often at the time of diagnosis, patients have about a year left before passing away. Prognosis is not very good with these tumors. So of the remaining gliomas, we have oligodendrogliomas tumors, and then we'll have the ependymal cell tumors. Oligodendrogliomas, if you remember, they have that fried egg appearance, and as you can see in the histology below, it looks like someone just took a couple eggs and just tossed them at the slide and maybe painted them purple, but a very classic fried egg appearance of these cells. So histologically, that becomes something that you can use for diagnosis. But overall, these are tumors that occur late in life, and they're not relatively common, less than 50% overall. They tend to be well circumscribed, sometimes calcifications and hemorrhaging and cysts and things like that. But you can look, I mean, the tumor doesn't look great, kind of like a tan, white, gray appearance, but it's moderately circumscribed. Depending on location, may be amenable to some sort of treatment or resection, but it really just kind of depends. We have to kind of take these case-by-case basis. But overall, they're relatively on the benign, or we'll say low grade going forward. And then we have the ependymomas, which of the gliomas is probably the most fun to say, ependymoma. So these are the ones that are going to arise in that ependymal lining of the ventricles. Now, if these arise in the lateral ventricles, usually they can be non-problematic, and usually you got enough space in the ventricle where it can be taken care of, or you can probably start resecting it piece by piece. However, if they occur in the posterior fossa or in that skull base region, so we're looking at like the aqueduct or the fourth ventricle, now we run the risk of A, being very difficult to resect because of the location, and B, we start blocking cerebrospinal fluid from exiting the ventricle system. And now you're at risk for hydrocephalus. So these can start experiencing very painful symptoms in that regard. So if it is in that region, these tumors tend to have a lower prognosis than ones that are found along the upper portions of the ventricular system. The final cell type in the nervous system that we looked at was neurons, and so neuromas are a possible tumor that you can encounter, but these are very uncommon tumors, and the most common you tend to see are kind of a combination from neural cells and glial cells called a ganglioglioma. And this is very similar to like pleomorphic sarcoma, which is going to have sarcoma cells and epithelial cells in the mix of the tumor, but that's the nervous system's variation of that. These tend to be more likely found in the temporal lobe, which means they're going to be often associated with seizures, and they can appear cystic, but they're, like I said, not very common. In fact, the one that you probably are most familiar with, the acoustic neuroma, is really not a neuroma at all. It's actually a schwannoma, which is similar to an oligodendroglioma. And that's going to be a tumor of those myelin-producing cells along your 7th and 8th cranial nerve there. But they often are called acoustic neuromas, which is a misnomer in that regard. Looking at a few childhood tumors, so you have medulloblastomas. These are grade 4 tumors, but they're also very amenable to radiotherapy, and so prognosis tends to be pretty good. 5-year survival, I think, is about 75%. Contrast that to a rhabdoid tumor, which is going to be a highly malignant, highly aggressive tumor found in the posterior fossa. They're not amenable to treatment. Oftentimes at the time of diagnosis, the patient has less than a year to live, which is unfortunate, just due to the high aggressive nature of it, as well as the location. Again, keeping in mind that posterior fossa is probably the worst place to get these tumors. And then meningiomas are the most common primary brain tumor, if you'll recall, more common in women. But here's a case I worked on, and you can see they don't look too threatening. If we wanted to describe that, we would say it's well circumscribed, homogeneous tan white, fleshy cut surface. Although you don't want to use fleshy, that's usually synonymous with lymphomas. But they look okay, and they're just going to be tumors arising from the arachnoid matter, so you can easily go in and resect them off those the meninges there. And oftentimes it's fine. But the worst case with these is that they do tend to be pushing on brain tissue, and they can cause other issues down the road, potentially herniations or hemorrhaging. These are considered benign, but again, I don't like using the word benign. I'd rather call them low grade, in the fact that there is a small likelihood that some of these tumors can actually become anaplastic and invade into the neurotissue. And when that's the case, it's not really a different tumor. It's still a meningioma from the same cells, but it's just started to invade. So low grade is kind of the exception to the benign versus malignant rule. I like using that when tumors have a potential to become harmful, but they usually don't. But overall, relatively common, so you probably get a lot of these specimens, and they're relatively fun to grow, so I think usually have a piece of dura attached, which is kind of cool. And then finally, metastatic brain tumors. These are, again, the most common brain tumor, non-primary brain tumor. And the easiest way to tell if it's metastatic is if there's multiple nodules within the brain. Remember, that's a classic presentation of metastatic disease, and you see that also in liver. A lot of tumors metastasize to the liver, and you can see multiple nodules spread throughout. But they tend to be tan white, necrotic, and they'll have similar cells to their originating tissue. The most common cancers that metastasize to this are going to be lung, breast, melanoma, kidney, and colon, but that's not an inclusive list. Any cancer can theoretically metastasize to the brain. These just happen to be the most common to do so, so it's worth noting that you'll see those. But usually if you metastasize to the brain, those cancers are already in a stage 4 prognosis, and usually not in a good shape, because again, it's hard to resect stuff in the brain. So this is the breakdown of that WHO rating system I alluded to earlier, and this is also taken from the ABTA primer, so you can use that as a guide as well. But you should be comfortable with this. You won't be able to specifically, it's going to be a lot more involved to just identify a tumor as a grade based off looking at it. In fact, here's the chart from CAP that shows you if you have a specific diagnosis, it's automatically associated with a specific grade. So like I said, you can never have a diffuse astrocytoma that's a grade 3, because then it's technically an anaplastic astrocytoma. But you should go through and be comfortable with the variations between a grade 1, 2, and 3 for the tumor types. And some of the very specific examples we gave in this lecture, because it doesn't involve the AJCC staging where we do T, M, and N, as well as the grading system involved with that. So we don't have that overarching stage of cancers in the brain like you do see with other tumor types. So very unique in its presentation. You also see that with lymphomas, they kind of have their own grading staging system as well. So, but a 4-grade system is not that hard to know, in my opinion. So as an example of some of the brain tumors you can get, by no means is that list exhaustive. Here are just several examples of other tumors you can find in the brain. And if we break that down into different types, you can get neurological origin, which was what we're more concerned about, being primary brain tumors. But you can get non-neurological origin tumors, such as lymphomas, lipomas, osteosarcomas, things like that, can also be found in the brain area. And so we're worried about all kinds of different types. So it's really got its own ecosystem of tumor types, and what we covered today was just sort of a splash in the bucket. But those tend to be the most common ones and the stuff you should be mostly encountering, and if you experience anything else, it doesn't hurt to go do a brush up of research on it. Okay, so let's say you're like me and you have a couple of headaches and you start being forgetful for silly things, and so you're convinced you have a brain tumor. What do? Do you just automatically go and get it biopsied and call it a day? No, and we'll see why. When we think about brain lesions, I like to call back this quote from Oliver Sacks. And this book, The Man Who Mistook His Wife for Head, is a very cool book. He goes into some of the cases he's worked on, and a lot of it is more neurological, neuroscience type stuff, and not just always clinical diseases like tumors and things like that. So we don't really get into some of those cases, but I do find pathology of the brain to be fascinating because it really is a sense of our identity. And the quote states, if a man has lost a leg or an eye, he knows that he has lost a leg or an eye. But if he's lost a self, himself, he cannot know it because he's no longer there to know it. And I find that fascinating because it's true. I kept saying we can't just resect parts of the brain. We can't just take out portions of our upper hemispheres because, there's a tumor there, because ultimately that's going to change who we are. And the other problem to that is even if we do get certain pathologies of the brain, whether they're tumors, infections, or any other disease processes, they can ultimately alter who we are as a person. And it's not uncommon for people to start hallucinating or seeing things, and to them that's real. It becomes fact in life. But to everyone else around them, trying to convince them that it's not right becomes a difficult task. So it's easy for us to go resect portions of the colon or the liver and the patient to be fine, but we don't get that same benefit for the brain, and so going in and doing biopsies becomes difficult. Another classic example is that of Phineas Gage. He was a railroad worker who got a spike driven up through his eye and into his frontal lobe, and it basically shifted his personality because of this essentially induced lobotomy. He was always described as a nice person beforehand, and then after this railroad spike went through his head, there was a shift, and he became much more agitated and angry and a disgruntled person. And maybe that's just getting older and fed up with people's BS, but there's definitely an attribution to the loss of some of his frontal lobe. And if you're really interested, there's a Lego demonstration of the Phineas Gage story that I highly recommend. But what we're going to do for brain tumors is go through a very process from least invasive to most invasive. Now, the most invasive is a biopsy, but that is also the gold standard, and ultimately that's what we want to get to if we suspect brain tumor. But just going in and thinking you have a brain tumor is not going to want us, we're not going to want to take a biopsy from that right away until we have a reason to do so. And think about that. If you have a mole on your arm that you're worried is melanoma, you can go to a dermatologist and they'll happily take that mole off, take a nice fat paycheck for it, and then tell you, no, it was just a mole, you crazy man or woman. But we don't do that for the brain. We can't just go in and take a part and hope for the best. So we're going to start with neurological exams, go into some imaging, maybe some lab tests, and then ultimately the final thing we'll do is biopsies and then possible resection. But we'll also see that a lot of these tumors are non-resectable, which I kept reiterating throughout this lecture. So I don't expect you to know the basics of a neurological exam, but basically what we're going to do is test all the cranial nerves, or the clinician will test all the cranial nerves and make sure everything's working, making sure that the person has a right sense of being and proprioception, and kind of just doing some basic tests for that. And that way, if they see some of those deficits, they can start narrowing in on where the problem might be. We already talked about herniations that can result in that ocular motor nerve palsy. So, looking at the pupil, if you see a droopy eye and dilated pupil, you'd be like, oh, it looks like your ocular motor nerve might be blown out on your left side because your left eye is incredibly dilated. So that can help narrow it down. Additionally, we'll do other clinical correlates to help narrow down where these lesions are. So the nice thing about the brain is we don't just have to go in willy-nilly. I mean, we obviously have imaging to help, but just by doing some basic assessment of the person's behavior or symptoms, we can actually kind of narrow down where the tumor might be located. So we do get the general symptoms of like a headache and vomiting and nausea, but we can see things like hormonal changes. If it's an endocrine tumor in the pituitary, we can see behavior and mood swings, memory loss and things like that, based off if the central lobe, based off the lobe that the tumor is located in. And so going through these frontal lobe tumors, for instance, are going to show a general lack of interest in surroundings. Basically, your higher thought processes are now being compromised. So you might have changes in mood, memory deficits. You might just have a change in ethical standards, which I find funny, but not funny, I guess. But I always like to imagine someone like, oh no, don't steal, and you get a brain tumor. You're like, stealing's fine. So things like that could be associated with frontal lobe tumors. But contrast that to parietal lobe tumors. And in that case, we're basically affecting our proprioception. So we might have an inability to have communication between our left and right sides. We might not be able to really secure our place in the environment. You might see patients bumping into things or having issues with sensation. There's also temporal tumors. So this is kind of our state of being. We might start feeling, the patient might just have this general sense of like dreaminess, like they're barely existing. They might start getting hallucinations. You're very close to your Broca's and Wernicke's area, so you might start hearing sounds and hallucinating sounds or not being able to hear things appropriately. And then occipital tumors, our visual cortex. Getting tumors there, we can get anything from double vision to loss of vision to visual hallucinations from tumors. So all those symptoms basically play a role in thinking like, okay, well now we can generally locate where those tumors are, especially if then there's the cerebral hemispheres. When we start getting into some of the more primal brain structures, like the central brain, hindbrain components, it becomes a little more difficult, and a lot of our life-sustaining functions are going to be inhibited as well. So I talked about skull-based tumors and brainstem tumors along that. Skull-based tumors tend to be very problematic because they're hard to access, but because of the location of the skull base, we're really worried about things like our olfactory nerves, our optic nerves, anything on the lower aspect of our brain there. We start impeding on our brain stems. We might have difficulty in swallowing or even just digesting. Brainstem tumors, so this is where we ran into those issues with the tonsillar herniations. So all our life-sustaining functions are located in the brainstem. So we might have difficulty swallowing, breathing, moving, anything, especially like if we're dealing with cerebellar injuries or medulla injuries or tumors. And then I mentioned hormone dysfunction. So pituitary tumors are actually considered endocrine tumors, so we won't get into those, but that's something to be mindful of, that if you have a pituitary adenoma, you could see changes in hormone levels that are definitely worth testing and seeing the difference in those. And one thing I'll point out, and you'll get more of this in your endocrine lecture, with endocrine tumors, the more problematic tumor tends to actually be the benign adenoma or the low-grade tumors. Because when you're dealing with low-grade cells, they tend to maintain their original function. You just have more of them. And so if they're doing the same thing but times 20, we start seeing problems. So a good example is if you have tumors arising from your somatotroph cells, which are exhibiting your growth hormone. If that happens in a child, they might start showing signs of gigantism and being very large. Whereas in an adult, we just see very specific areas of growth, so usually around the jaw and joints and things like that. But that's because your pituitary has an abundance of these cells producing growth hormone. Contrary to that, if for some reason your cells were deficit or a tumor, a high-grade tumor of these cells, you might not get enough of these growth hormones, and you'll see the opposite effect. X-rays can be done, but they're not usually done. So if you do suspect a brain lesion, chances are you're not going to get an X-ray, and it makes sense. I mean, you don't really see anything that's going on in the brain here with the soft tissue. If there was some sort of fracture, we might want to do that, or a hematoma forming, sure. But usually there's going to be assigned to any sort of like bony type lesion occurring from the skull. So typically what we're going to do is CT or MRI scans. And MRI scans, if you remember back from the imaging lecture, those tend to be done for neurological cases, and they are actually the gold standard for brain tumor imaging because you get a really high definition look at what brain tumors are going on, or all that soft tissue in the skull there. And CT scans and angiographs can also be used with contrast or not. And we saw some CT scans and they look fine. But ideally, if you can do an MRI, that's the best. And a couple others, you can do magnetic resonance spectroscopy or PET scans. And basically there you're looking for metabolites or physiological functions. Remember, PET scans are done to like test physiology. So if we have a rapidly growing tumor, we can do these radioactive sugars and see these tumors taking up these sugars really quickly. And they'll show up as big old black lights on the PET scan. So if you do suspect a tumor, you can also do a lumbar puncture. Now this may or may not be done depending on what you're suspecting the tumor to be, but all tumors tend to have tumor markers that will be emitted, and a lot of times in the systemic tumors, we see that in the blood supply. But here we can actually see those in the cerebral spinal fluid. So you can tap into that and start looking for those markers. Now we mentioned a bunch of other tumors. Germ cell tumors were something possible that you could see in the brain. So you might see things like human gonadotrophic hormone or alpha-fetoprotein. But any tumors in the arachnoidea matter can get CEA. Usually you're not going to get lab or lumbar punctures for most brain tumors, but it is another way to help with evaluation. Endocrine tumors, we talked about the pituitary. You can see all your hormones in the cerebral spinal fluid as well. So here's just a list of the abbreviations of some of those if you're a lab geek and want to know. So now we can get into the surgical pathology specimens we'll see for brain specimens. Now, spoilers, it's not very exciting. I kept mentioning over and over again, we don't see a lot of resections for the brain for tumors, so you're not going to get a lot of specimens unless it's going to be palliative care. However, we do in cases of seizures. If the patient is suffering from epilepsy, sometimes they'll go in and remove portions of lobes of the brain to try to adjust that. Some areas in the temporal lobe can kind of be removed relatively safely. But the main specimens we'll see are types of biopsies, whether it's going to be brain or dural. And brain biopsies will probably be the most common specimen you'll receive in this area. Then you'll get hematomas, particularly for those epidural and subdurals. And then on the rare occasion, you might get a brain resection. And I think I've seen maybe two, one for sure, maybe a second one, if I recall correctly. So brain biopsies, these are just going to be small fragments of neurotissue. They're usually tan white and friable. Oftentimes, these are going to be sent for intraoperative consultation just to get an initial diagnosis of the tumor. However, you can still treat these non-intraoperatively just to get permanent sections in order to confirm that diagnosis, because it's not like they're going to do any additional resection in the surgery suite. Oh, I should say they're not often going to do that. But if you get some of these specimens, you just treat them like any of your other biopsies. You're going to measure it in 3D, and you might have an aggregate of tissue, or it might be a single fragment, and sometimes you just get like a 1 to 2 millimeter piece, and they expect you to do a frozen section on that. And so you got to get real crafty. But you describe what you have, a tan white, friable fragment of tissue, and you're going to ultimately submit it entirely. So if you don't do it for a frozen section, then you're just going to wrap it in moist lens paper and submit it entirely. And if you want to run special studies because you're trying to decide what tumor you have and do a whole differential diagnosis, you can do that as well. So it really just going to depend on the tumor, because it could be anything from a lymphoma to a glioblastoma. I will say, if I had a neuropathologist when they were doing these for frozen, she liked to run two different types. So you do the regular frozen so you can see the architecture of the tumor. But what's also helpful for these tumors is to see the cell type, and sometimes to do that you want to do a smear or a touch prep, and you can see individual cell components, because that's equally helpful in doing a diagnosis on these. Occasionally you'll get dural biopsies. I've never seen one. They're very rare, because usually if it's a dural issue, they can either do a swab if they're worried about infection. They can do a lumbar puncture, or if it's a meningioma, they'll just resect that. But same thing, you're going to just describe it, measure it, and then submit entirely. So there's usually not a lot of cutting involved with these specimens. So if you get a case for an epidural or subdural hematoma, the blood clot can be sent down a surge path, and these are really just going to be therapeutic specimens. A lot of times there's really nothing going on with them, so you'll just describe it as a red-brown hemorrhagic material, measure it in 3D if it's just an aggregate or collection of fragments. However, sometimes you can get metastasis located in these hematomas, so maybe the hematoma is not a result of a busted vessel, but it's actually a result of maybe a metastatic tumor dislodging some of the vessels or ripping some of the vessels. So you do want to do your due diligence and serially section these completely. Describe the cut surface as being regular red-brown, or maybe there's fragments of firm tan white tissue or calcified areas. So if you do see anything unusual, that's the area you want to focus your sampling on. But oftentimes if you don't, or if it's just a normal hematoma, 1 cassette or maybe 2, depending on your hospital, is fine just to verify the diagnosis of hematoma. But again, anything suspicious, always focus your sectioning on that. And then brain prosections. So these are relatively rare. Again, most commonly done for epilepsy, but I believe this one was actually done for a tumor, and you can kind of see the outline of the tumor here. The reason why we don't do them for tumor, and particularly when you get these specimens, we're not really worried about margins, is because it's very difficult, as we saw with a lot of those grade 2, 3, and 4 tumors, and even with grade 1, it's hard to really identify where their margin is. And it's not like if the margin is positive, it's really easy to just go back and keep shaving off more brain tissue, right? So chances are, if you're taking this off, you can make the cost-benefit analysis of basically saying, all right, we can afford to lose this portion of the brain. It shouldn't be as impactful to the patient, but that doesn't give us the right to just kind of go in, all right, let's take off another couple of millimeters just to make sure we get the rest of the tumor. That being said, the reason why we don't prosect these is because if you're not going to get the entire tumor and it's just going to keep growing, all you've done is created a palliative treatment for the patient, and they'll eventually succumb to that tumor as well, and then they have to live with the side effects of losing some of that neuro tissue. So epilepsy tends to be the most curative function for these brain resections, but it's not out of the realm of reasoning to see that you might get one for tumors. So when you do get these, I did happen to ink this margin. I mean, I was a student when I got it, so I just inked everything. So it's not wrong necessarily, but it doesn't really help with anything because, like I said, they're not going to go back and take more tissue. At best, they'll say, yeah, there's residual tumor in there, and chances are there'll probably be residual tumor anyways. But inking is not usually necessary for the resection margin here. But what you will do is describe what you have. You can measure the specimen in 3D. Hopefully you don't receive it in aggregate, but sometimes you get brain fragments that some of these tumors can be received in like sort of chunk pieces, because all they can do is like just kind of go in, pull out pieces of the tumor at a time. But if you do get a nice whole section, let's go ahead and describe the outer surface, measure in 3D, describe our sulci and gyri that are present, any external features on those specimens. And then we're going to serially section. And it does say perpendicular to the pial surface, or a pial surface. What that means is the pia matter is basically going to be located on the surface right adhered to the brain tissue. So you don't want to cut like this. You want to basically cut perpendicular to the long axis. So don't overthink it. Just perpendicular to the long axis, making sure you can basically get a section like this where you have the outer brain going to the inner brain. So you can theoretically see gray matter here, going to white matter, going to resection margin. So when you cut these, you do want to describe the cut surface, describe any sort of cysts or lesions you see, whether there's necrosis or hemorrhaging. You want to see if you can notice any demarcation between gray matter and white matter. It's always worth noting. And then you're going to submit representative sections, and usually you'll do 1 per centimeter of the specimen. Like normally for tumors, we'll do 1 per greatest dimension of the tumor. Here, if you got a tumor, so this one looks like it's what, about 6 centimeters, you can do 6 sections of that. And if you can, you might as well just show the relationship to the quote-unquote resection margin. I mean, if you inked it like I did, you might as well put it in there, right, just for documentation. But ideally, if you can get like these nice cross sections here to show the relationship from the external surface to the internal, those are helpful as well. So now, as a bonus, we'll look into whole brain cutting, and you won't get these as surgical path specimens simply because we don't have brain transplants yet. And technically you couldn't do a brain transplant because a brain is identity based off what I just said earlier. So it'd be like a whole body transplant. If you needed a new body, just put your brain in the new one. But we're not there yet, maybe in the future. So these are for autopsy specimens. And what you're typically going to do is serially section the brain in the coronal section or the coronal plane from anterior to posterior. And we'll do representative sections based off general suspicion for possible pathologies. If you get a case where you suspect a very specific neurological pathology, well then you'll probably treat it a little bit differently, and chances are you'll fix the brain for about 2 weeks so that you can get really good cuts on that. But any autopsy, you're going to do a brain removal, you'll do a brain review and just look at the cross sections, and then you'll submit some representative sections just like you do with the rest of the case. So what we'll do here, the method I actually like to do to make sure you get really good cuts and to make it easier to find the sections you need, is I'll actually look for my mammillary bodies. So you can see them highlighted in orange right there. And let's see if I can get them with the pointer. I hope this pointer is working. But I'll start with that. Oops. I'll start with that as my cutting surface, and then, oops, basically cut a line through there, and then work my way out anteriorly and posteriorly from that point. And then you should get a nice layout from here. Now, you can leave the brainstem attached if you want, but another technique is to just cut it off at the midbrain, and that lets you see the substantia nigra right away and let you know whether it's colored or discolored. But by cutting the upper hemisphere through this way, through the mammillary bodies, what we'll get is this nice section that we looked at earlier that's going to show you all the pertinent structures that we need to look for submission. So let's say you just want to do a general approach. We don't know if the patient had any history of any particular neurological disease. So here's some of your 5 targets samples to aim for, and the reason to aim for them. So first we want to rule out any sort of infarction or dementia, and that's going to basically be located in our outer hemisphere, so on our gyri and sulci from the outer region. So we'll target so if we're looking at this brain cut in the section we just made, we'll probably get a section here to include white matter and gray matter, and particularly target in that watershed area. So remember, our blood supply is going to come up through the middle and going to come out through the temporal lobe region. So we want to get something right around here where our blood supply would be most minimal. And that'll tell us if there was any sort of ischemia, maybe potential emboli or something like that. And it'll also tell us if there's any potential signs of dementia. If you don't necessarily see those degenerated gyri, you can maybe catch potentially early signs of Alzheimer's through the look of those tangles and the amyloid plaques. We're also going to get sections of our basal ganglia. Remember, those are pretty important in determining any sort of movement disorders. We can also look for lacunar infarcts, which can be relatively common in autopsy findings because of hypertension. So we'll take an extra section right there through our basal ganglia in that little triangle area to look for those diseases. It's worth documenting. Our hippocampus, we mentioned, is going to be that little cinnamon roll in the brain right around the amygdala. And the interesting thing about the hippocampus is it's really the area that becomes most prone to hypoxic changes in the brain. So if the patient exhibited any sort of hypoxia, systemic hypoxia, we would see degradation of the hippocampus first. And so by taking sections of that, we can really rule that out. And you can also look for things like dementia and epilepsy there as well, because that's kind of associated with our temporal lobe region. So again, it's worth taking sections of that region. And that tends to be the hardest section to find, but ideally, if you made your cut well through that mammillary body, it should be right there through the center component. And then not pictured here, but if we're looking at the brainstem and cerebellum, that's when we would look for that substantia nigra in the midbrain and try to get that colored section or show that it's not colored for Parkinson's disease. And then we'll get representative sections of our cerebellum because that'll tell us, A, if there's any sort of movement disorders. So a patient experiencing ataxia would definitely have changes in their cerebellum, but also toxic changes and signs of hypoxia can be demonstrated in the cerebellum as well. So it's worth getting a section of that to include also gray matter and white matter. And then finally, here's a couple of your CPT codes for the brain, basically anything from a 305 to a 309. I guess occasionally you could theoretically get a foreign body in the brain area, so that would be a 88300. But most of the time you're just going to be dealing with brain biopsies for these specimens. So now let's jump into the eye and look at the anatomy, histology, and pathologies of the eye specimens. So we'll go ahead and start. You can look at my new iPad here, one of the enucleation specimens I got. And at least on these cases, they're a little more interesting than the brain specimens we were just looking at. So starting with the anatomy and histology, we can go ahead and begin with the external eye, namely the components surrounding the eyeball. So we have our eyelid, and the eyelid is going to actually converge on 2 canthuses. The medial and lateral canthus, respectively, given their location. The external surface of the eyelid is going to be comprised of stratified squamous epithelium, consistent with skin, while underneath, the underlying area of that is referred to as conjunctiva, which contains a mucosal layer. And the mucosal layer is actually going to be continuous with the eyeball and cover the sclera there as well. There are two different divisions of the conjunctiva. The portion on the eye itself is referred to as bulbar conjunctiva, and the portion underneath the eyelid is the prepupal conjunctiva. And those are important because they are prone to getting epithelial type diseases, infections, or cancers. And then if we look at the eye itself, we have the three main layers. So the outer layer, that white layer, is our sclera. The innermost layer is our retina, and then we have the choroid on the median aspect of that, or sorry, the middle aspect. The choroid is going to be continuous with the ciliary bodies, which are muscle structures that are going to be functioning in either dilating or constricting our pupil. The ciliary bodies are continuous with the iris, and that's going to be the colored portion around the eye. We also get this portion of sclera and epithelial tissue on the external portion of the eye that becomes transparent, and that's our cornea, and it's going to be this raised area. Now the region around our cornea and iris, where they kind of join, that area becomes the limbus, that boundary, and we'll take a look at that when we actually see the eye. Actually, you can see it here. It's where you kind of see like the coloration stop. That's our limbus. And those are kind of the main functions of the eye itself. We also have the anterior and posterior compartments, which contain aqueous and vitreous fluids respectively, and then you should be able to see the optic nerve posteriorly, or on the posterior side. Additionally, if we're looking at the eye from the posterior section, we should be able to see the optic nerve, and occasionally you'll be able to see, if you get these for resection, some of these vessels, although they're usually too small and they're really hard to differentiate on an enucleation specimen, but they're there and they can theoretically be used for orientation, especially the posterior ciliary vessel here. You also have your 6 ocular muscles, your 4 rectus muscles, which are superior, inferior, medial, and lateral rectus, and then you have your superior oblique and your inferior oblique, which are usually going to be, or not usually, but they are going to be attached on the lateral aspect and move towards the midline of the body there. So if those are present, you can use the oblique muscles to help you orient the specimen as well. But again, a lot of times when you receive these specimens, they're really not present. And actually, if you want to go back to the one I saw here, so an enucleation specimen I received here, you really don't see any of the musculature attached. So orientation for these specimens is often difficult and really non-essential, and we'll talk about that when we get to surge path. So histologically, if your site is, or place of business is really into eyes, I guess you could say, they could do these whole mount sections for the eyes where you can get the nice coveted pupil to optic nerve section, or PO section, which we'll talk about later. But the goal there is to be able to see all components of the eye, including if there's any tumor present, in one section, and that way you can get a relationship and help really narrow down the diagnosis and potential staging of that case. So this is the histological component of everything we just looked at. So let's get into some basic eye pathology. Again, we're going to break this down into non-tumor versus tumor. We don't have to worry about mass effect with the eyeballs, because if there is a pathology or benign pathology, usually it can just kind of grow out of the eye socket area and maybe be uncomfortable but not be life-threatening as much as it was in the brain. So starting with non-tumor, we'll look at pterygiums and pinguiculas. Now, other than just being really difficult to say for most people, took me a while to get practice, overall these are relatively benign and common pathologies. You can think of them as essentially being sunburns on your eye, and the difference is really just in the location. So pinguiculas are actually going to be located on the outside of the limbus. So the limbus being the border here. On the outside of that, on the sclera or the bulbar conjunctiva, you'll see this growth of mucosal tissue, which is going to be the pinguicula. If that mucosal tissue growth happens to go over the cornea, as we see here in the far left, then we're dealing with a pterygium. And these are really easy to excise. Basically just remove them, pluck them off, and then send them to pathology to submit entirely. So some other common pathologies that we'll see are cataracts and glaucoma. A cataract is just going to be sort of a cloudiness or an opacity of the lens itself, and this could be either acquired, and sometimes acquired can be through glaucoma, or it can be congenital. So you can get congenital cataracts that have to be taken care of early in the patient's life. But cataracts can easily be fixed by just replacing the lens, and you can go online and look for videos of cataract surgeries. If you're not too squeamish, you should be able to enjoy that. A glaucoma, or glaucomas in general, it's just any sort of condition where we actually get any changes in the visual field. So where cataracts will just give you an overall cloudiness and lack of definition in your visual field, glaucomas tend to start reducing your visual field due to some intraocular pressure. And that buildup can ultimately lead to blindness or cataracts itself as you start damaging the lens and the internal retina tissue from the eye pressure inside. The most common cause of Western blindness is due to ocular diabetes. So diabetes is really good at disrupting our nervous system. So we see peripheral neuropathies in the lower extremities for patients with diabetes, but you can also see retinopathies where the optical nerve starts getting damaged. And this can ultimately cause blindness in the individual as well. And that will usually be the primary reason for resection of the eye. Benign reason, I should say, is due to some sort of glaucoma or basically a blindness where the eye is not functioning and now you're just increasing the risk for infection. So here's a couple of images. So over here you can kind of see the difference between the cataract lens on the far left and sort of a normal lens, getting that cloudiness, and down here you can kind of see the close-up version. The image over here, you can kind of see that the sort of bloodshot eye appearance and the overall kind of cloudiness of the iris as well. And so this patient is experiencing glaucoma, increased pressure, which will cause like strain and undue stress to the eye itself, and eventually could disrupt the cataract or the lens as well, creating a cataract. So a lot of times they're going to be seen in conjunction with each other. So you'll get a lens or an enucleation specimen that'll be that'll have a cataract or signs of a cataract, but it was taken out for glaucoma, because there's no reason to take out an eye for a bad lens. You can just replace the lens rather than losing the whole eye. So you don't need to overtreat in that case. Infections, just like in the brain, you get a couple of infections that are worth noting. Conjunctitis is just any infection of the conjunctiva we talked about. Remember, the one under the eyelid and on the eye. This is usually caused as a result from chlamydia trachomatis. And the problem with infections, and we'll see with all these types, is they can lead to scarring on the eye, which can be painful or maybe an increased risk of infections later on, particularly in keratitis, which is corneal reflection. Corneal infection, and this can be seen in any type of infectious agent, from bacterial to protozoa, and this could lead to corneal ulceration, which can cause problems with vision down the road. Fortunately, there are such things as corneal transplants, so if you do have prolonged infections, you can go ahead and get that cornea replaced and hopefully be fine at the end of the day. The retina, so this is problematic because the inside of the eye is now infected, so it becomes difficult to know that there's an infection other than maybe just a painful occurrence of the eye, maybe some inflammatory response like you see down below here with some of the bloodshotness. But what ultimately happens, particularly in toxoplasmosis, is we can get scarring of the retina, which will lead to blindness in that regard, because now we're starting to damage some of our actual ocular functional cells. So the retinal infections tend to be the most problematic out of these groups. Now, when we look at neoplasms, there's a couple of benign neoplasms that we can talk about. So if we're dealing with young children, they're more likely to get capillary hemangiomas, which are just tumors of the blood vessels. And as you can see in this one over here, it's really just going to be this red tumor, and you can get these just about any location. A lot of times, especially in children, they tend to regress on their own, and surgical intervention is not often needed, but if it is, it's usually a relatively straightforward surgery. You can just go in and resect that tumor. In young adults or even in older adults, you can get lymphangiomas and cavernous hemangiomas. Cavernous hemangiomas tend to be a little more prone to being invasive than the capillary variants. And lymphangiomas are really just tumors of excessive growth of lymphatic ducts and vessels. So again, these are relatively benign, and definitely you can see how they'd probably be very uncomfortable to have. If they don't regress on their own, surgical intervention is usually pretty curative for a lot of these cases. So you don't often have to worry about them being infiltrative or locally invasive, which is good. Now compare that to the carcinomas, which are definitely locally invasive. So the two variants that we'll talk about externally are our basal cell carcinoma and our squamous cell carcinoma. And so these are going to be the most common external eyelid or external eye malignancies. Basal cell carcinomas tend to find themselves on the eyelid, whereas squamous cells will actually form on the conjunctiva itself. So you'll get a tumor that's actually forming on the eye. And what's interesting about the squamous cell carcinoma is it does have a normal progressive track, similar to what we see in cervical carcinoma cases, which means you start with an in situ lesion, so carcinoma in situ, and this will be known as conjunctival intraepithelial neoplasia. So CIN, so don't get it confused with cervical intraepithelial neoplasia, which is also CIN. So make sure you're very specific about what part of the body you're talking about. But what you'll see is that'll progress where you'll have a bunch of malignant cells that are just forming above the basement membrane. And they are absolutely malignant, but they're non-invasive. And so sometimes it's a matter of, do you go in and resect or treat, or do you just wait till it becomes invasive? Because technically it's not really a carcinoma until we have some sort of invasive symptom. And so when they do become invasive, then they can be problematic, especially if it's at the conjunctiva there. And here you can see the difference. So again, basal cell you typically find on the eyelid where the squamous cell epithelium is identified, whereas here on the conjunctiva, that bulbar conjunctiva, we see their squamous cell carcinoma developing. And as you can imagine, that'd probably be very uncomfortable and potentially invasive into the eye, but it also is going to be locally invasive around the eye structure. So now we're starting to worry about, even with the basal cell carcinoma, are we involving the nasal cavity or some of the bones around that, or are we potentially getting local invasion into the optic nerve and eventually into the brain? So these become very problematic and need immediate attention for that. Now, when we look intraocularly, we look at melanomas as being one of the most common intraocular primary tumors. So again, we have to play that game. Is this a primary tumor or is this just a regular tumor? Because the most common tumor that you'll find in the eye is actually metastasis. So actually metastasis can occur in the eye just like it can occur in the brain. But if we're dealing with primary, then we're dealing with melanoma. And you can see here, melanoma doesn't have that characteristic pigmented look that you'll notice on the skin. Melanoma is interesting because you can really get it anywhere in the body, and that's also what kind of makes it scary, and particularly in the eye. So the problems with eyes are much like the problem with the brain. So if you have something going on in your brain, slowly and slowly you'll start losing your mind, figuratively and literally, and you won't know it. In the eye, what happens is these tumors start to grow kind of gradually, and so you get a lower and lower visual acuity, and eventually your field of vision just is gone, but you didn't notice it because it took a couple weeks or months before that happened, and you have a big old tumor in your eye. And so they can go in, and usually in this case you can kind of see, if they were to look in the eye, they could see this growth here and know that you do indeed have a tumor, but it might be kind of late for that, and we are worried about that local invasion outside the orbit or the globe there, as well as the greater dimension of that eye can be prognostic factors, or not, the greater dimension of that tumor can be a prognostic factor. These tumors tend to be responsive to radiotherapy, but ultimately the common treatment is an enucleation, where you just get it out of there. That way you don't have to worry about it. Better safe than sorry, because you don't, again, want that to metastasize, especially to the brain, because then it becomes significantly worse in that regard. The most common intraocular tumor in children is actually a retinoblastoma. And these tend to be mostly hereditary, and these are really a great example of the two-hit hypothesis for tumors, which means you might have a single mutated allele, this RB allele, but it isn't until you get that second allele, where the second allele mutates, that you'll get the tumor to arise. And again, you can kind of see the contrast in the vision. We sort of get that reflection of the retinoblastoma in the child's left eye there. So typically, childhood tumors like retinoblastomas can be treatable, and a lot of times you can get treat them with radioactivity, and hopefully they'll go down and basically dissipate. But if not, then you do have to go in and get an enucleation. So between melanoma and retinoblastoma, those are really the primary reasons you're going to get an enucleation specimen in the lab for a lesion. If it's not a lesion, then it's typically going to be glaucoma. And we'll go ahead and follow up with that shortly as well. And just like we saw in the brain, the eye is also prone to getting a lymphoma. Lymphomas can be found anywhere. Non-Hodgkin's tend to be relegated to the lacrimal system, but you can also get primary retinal lymphoma, which is going to be relatively aggressive in older individuals. And this may be similar to uveitis, and uveitis is really a conjunction of that choroid with the ciliary body, so it's kind of the inner layer of your eye wall. And so sometimes you think it's just an infection, and you might get antibiotics to try to clear it up, but it's really lymphoma. a primary lymphoma from the eye, mirroring an infection. And again, what we're also worried about is either being involved with the brain or transferring or metastasizing to the brain for these lesions. So it's important to get these caught, or any sort of symptoms be evaluated pretty thoroughly. So now we get into surgical pathology, and like I said, this is at least more interesting in my opinion than the brain surgical pathology. And I should also preface this that if you're a little squeamish, and I probably should have said earlier, maybe some of these images are viewer discretion is advised, I'll say, going forward. So the surgical specimens we'll receive are foreign bodies and anything that's associated with some of the specimens that we talked about earlier. You'll also get corneal transplants. I know I told you that that's a thing, and some of those lens, you'll actually get those specimens as well. And then enucleations, again, for either a primary tumor like melanoma or retinoblastoma or glaucoma. You won't get them for pinguiculas, you won't get them for cataracts and things like that. And typically, the only reason you'll get them for if an associated foreign body is if there's severe damage that might cause blindness or infection. And really, it's that infection that we're worried about. So you don't want to just leave dead or dying tissue in the body, because that's going to be prone to a source of infection, and then that can transfer to the brain and cause really catastrophic effects. So that's ultimately why they'll do these for things like glaucoma rather than just leaving a non-functioning eye in the body. The last one here we'll just kind of go over briefly at the end of the lecture. You are not going to be responsible for these orbit resections for significantly invasive carcinoma just yet. Give it a couple months and this stuff will make sense, but because this is kind of one of your early guides to prosection, that's a much more advanced prosection description than what you guys need to take away from this lecture. So we'll look at that, and hopefully you'll be impressed, and then come back to this lecture when you got your skills to pay the bills, and you can look over those resections and say, oh yeah, that's pretty straightforward, I got that. So let's go ahead and look into it. So prosections for foreign bodies and pterygiums, or pinguiculas in this case, if you get them, are pretty straightforward. So foreign bodies are really just going to be, anything we do with a gross only, right? You get it, you measure it in 3D and describe. You can say it's consistent with nail or consistent with glass, but you don't usually just say, yep, it's a piece of nail. A lot of these specimens you do tend to photograph, or at least have a pathologist come and just double check and say, yep, looks good. And some places are fine with out photography and you basically being the eyes of the pathologist, which is kind of cool. You usually don't submit these unless you see any attached soft tissue. And then in that case, you're just going to submit the tissue and not the foreign body. Your histotechs will get mighty pissed off if you start submitting foreign bodies, I can assure you. With pterygiums or pinguiculas, it's just going to be a little fragment of tissue, so treat it like a biopsy. It's going to be these tan white tissue fragments, and usually they're going to be attached to like a cotton swab or something small because they're so minute. And so what you do is you just measure it, describe it as tan white, tan pink tissue, tan brown tissue, whatever it looks like, and submit entirely. So typically you'll get either lens paper, or you might have a mesh cassette like a biopsy cassette, and you can just submit it in there and call it a day. But no sectioning needed of any of those. So next we'll look at cornea and lens prosections, and these also are relatively straightforward. So if you get a cornea for corneal transplants, you're just going to measure the specimen in 3D, describe it. You can serially section or usually just bisect it and submit it on edge. And usually these specimens, and a lot of these ocular specimens, you're actually going to order PAS stains on. Now that's also helpful for identifying things like fungal infections, but it really helps highlight some of the histological features of the eye and some of the histological anatomy there. With lens, you're going to measure that in 3D and describe the same. You'll talk about the color, opacity, especially you're going to get these things for cataracts, so you kind of want to describe that sort of appearance. You want to see how thick these specimens are, how pliable they are. Sometimes they're very rigid and firm, sometimes they're soft. With lens, it depends on your lab. Sometimes they won't even submit them. They'll treat them as gross only specimens, but you can actually section these and submit them and look at them histologically. And they are pretty interesting. So if you are going to section them, just bisect or serially section, submit it entirely on edge as well. And again, order the PAS to kind of highlight those histological features for these specimens. And at last, for the reason you're all here, the enucleation prosection. So these are kind of the big prosection to take away from this unit. And these are just getting the eye globe. So you're not getting any of the surrounding soft tissue. You're only going to get a piece of eye and a portion of the optic nerve. So when you get these specimens, they look like they should be complicated, but realistically they're not. Oftentimes you can get away with one primary section, so that pupil to optic nerve section that we talked about initially, that's really what you're striving for here. And you can refer to the lab video to kind of see how that looks and functions, and then you can try that in lab as well. And once you get that, depending on whether this is for tumor or something benign, will dictate whether you're going to submit additional sections as well. So the most important thing to say about these specimens is you're going to fix these for at least a day, but usually up to 48 hours, depending on what your lab will allow you to get away with. And the reason for that is we really want to solidify the internal structures. So that retina is really easy to detach if we start cutting into these right away. And that tends to be a problem with the specimens we get in lab. They're not fixed usually, and if we're dealing with them fresh, you'll see how the retina can detach. And that can be problematic when we're dealing with surge path specimens, because if that detaches, and we see that on histology, that's synonymous with some potential pathologies. Was that an issue of retinopathy? Or was that maybe an issue where there was a tumor attached? The other thing to keep in mind is we don't want to open these specimens until we've taken our optic nerve margin. Another thing to note is some places might say go ahead and inject formalin in the eye in order to help it fix faster, or maybe just make a small incision, let the formalin get in the vitreous area and start fixing it a little bit quicker. You don't really need to do that. The 48 hours is more than sufficient to fix these small eyes entirely. And the problem is if you start sticking needles or making incisions, you run that risk of, again, disrupting the retina and maybe detaching it and giving us a false sense of pathology that isn't really there. So the first thing is you get this specimen, you get really excited that you're going to do an eye today, and then you realize, oh shoot, I have to fix it for 2 days. So you plop it in the formalin, and then you just get excited and kind of think like 2 days before Christmas, where you just can't wait to open your presents. And that's what these specimens are like. So your 48 days are up. You've been doing nothing but thinking about eyes for those 2 days. So now what do? You're going to try your best to orient these specimens, but that's not often easy. Now, if orientation is critical, or you see a reason to orient the specimen, oftentimes you're going to need to contact the surgeon for that. A lot of times, like the one I showed you, there's not a lot of attached musculature, and if you can find that posterior ciliary vessel, that's going to be located on the posterior, inferior, and medial side. So that'll kind of help you, but that's also hard to identify. Especially if you fixed it, that specimen might have retracted. So if you can orient it, your probably best bet is to orient it before the fixation. Also, if there is ocular muscles attached, look for those oblique muscles, which are going to be attached slightly on the left side, and you see those fibers going towards the medial side. That'll at least tell you lateral from medial. But the truth is, orientation is not usually critical, because we're probably going to rotate the eye in order to get the best section. So I showed you that PO section when we were going over the anatomy and histology, and basically we want to do that and include pathology in it. So if there's a tumor, we're going to just rotate the eye until we get a plane that we cut down and includes tumor in that central cavity of vitreous tumor. So after we've attempted to orient it, or given up on orienting it, or talked to the surgeon to get orientating tips, we're going to move into the measuring phase. So for these specimens, we're just going to measure the entire globe in 3D, and then we're going to measure the length and diameter of that optic nerve that should be attached. And so you'll do these on your specimens as well. You're going to describe the outer surface. We'll describe the sclera, the lens, the cornea, the pupil, the iris, any sort of scarring, how much of the blood vessels are coming through the sclera, if there's that bloodshot appearance maybe due to a glaucoma. And again, this might be something you can do before you fix it to really get more accurate feature description, because once we fix it, it kind of gets that little grayish brown discoloration. It's not as pleasant to look at, and it doesn't really tell us a whole lot. So, and you probably notice that too if you ever look at cadaver images of the eye. They're always just kind of sunken in and non-remarkable, I'll say. So then after you've done all that, we want to find this tumor. So we should have been looking at our patient history, right? We want to verify what this eye was submitted for. Was it glaucoma? Because if that's the case, we shouldn't expect to find a lesion. We just want to get our sections and submit them. But if it was for a tumor, one of our intraocular tumors, which should be either melanoma or retinoblastoma, and that's really going to be indication of age, Then we want to find that tumor and see how we're going to cut this specimen. So our first cut in this specimen, our first section is the most important, and we want to make sure we get it right. So we're going to take the eye, hold it up to a light source, and then just kind of look through and see if you can see an elevation where that lesion might be, or kind of a shadowing that kind of gives you an idea where that lesion should be. And that's the place that you want to make your eye cut on. So let's take a look at the images here, and these are taken from Wester. So if you look over on the far left there, so notice, let's say the eye was oriented superior, inferior, medial, lateral. Well, the tumor was located in this like superior medial region. So what they have to do is just rotate it and make sure you make a cut so that that tumor is going to be in the same plane as your pupil and your optic nerve. And that should be your first cut. So that's what the transillumination is for, and that's ultimately what we're going for. But before you do that, after you've kind of identified your tumor, let's go ahead and take care of our optic nerve, because again, we're worried about any sort of potential contamination or false positives. So we're going to ink our resection margin, which is our optic nerve in this case, and then we're going to shave it and submit it on phos, and then just put it aside before we open up anything else. And the reason for that is if we open up the specimen with a tumor and then we cut into the tumor and then there's tumor fragments getting everywhere and they happen to get on that optic nerve, well, now we've basically just shown that our optic nerve is potentially positive. So we've gotten that false positive. The pathologist is going to look at that and say, oh, our optic nerve margin is positive. You might want to go take back some additional nerve tissue if they can, or they might actually up this stage of the patient depending on how much nerve they took originally. So make sure you get your optic nerve done and taken care of before you do anything else. Now, if this is a non-malignancy case, typically that optic nerve margin and then the PO section is all you need. So it doesn't matter what plane it is. Let's say we got this for glaucoma. It doesn't matter if you cut it in a superior inferior plane or medial lateral plane or like an oblique plane. What you're going to do is make sure you get your pupil, and right here, your pupil and your optic nerve in one section. Now, if your place does have specialized cassettes for hole mounting, sometimes these sections can be a little thicker. What we're going to do in lab is basically use our standard cassettes, so try to get it as thin as you can, that 3mm to 4mm mark. And don't be afraid to use your scissors for these specimens too. When you get that cut, you can kind of trim up as you need to. But you do want to make sure you see that your optic nerve is attached and kind of faced for your histotex as well as your pupil. Now, if this is for malignancy, then as I mentioned before, our goal is to get that malignancy in the same plane as that cut. And then once we've done that, we're left with these two poles on either side that we cut off. And those are also referred to as cowlets. You'll see those referred to in the grossing guidelines, so either poles or cowlets. And you'll take those off, and after you've gotten your optic nerve margin and your PO section for the tumor, now you can take those poles, serially section them, and submit them entirely as well, and just submit your enucleation specimen in its entirety. So at the end of the day, here's what your section submission should look like. And here's a nice example of what that PO section looks like with a tumor attached. So again, we have our lens, cornea, we have our internal retina and external cornea, and then you see the optic nerve right there with a nice nuclear cloud looking tumor in all its glory. So that is what you're looking for. And so again, be mindful that you can rotate the eye. It rotates on a 360-degree axis, and just take the section that you need, right? So think about your plane of cuts. Then again, if you have no tumor and it's just glaucoma, PO section and optic nerve is generally fine. But if you do have tumor or you're suspecting some sort of other pathology, let's go ahead and submit those poles serially sectioned. And again, for these specimens, we'll order the PAS because that's going to help us identify things like our basement membranes and really just accent some of the ocular features histologically. And it's just kind of good to have that ordered right away. So as promised, we can take a look at orbit prosections. And so what you notice with the orbit prosection is we have skin and soft tissue attached. And in this specimen, now we have a lot more margins, a lot more things to be mindful of, a lot more relationships to keep track of. And so that's why I say these specimens, which are often referred to as composite specimens when they contain multiple parts, are a little more complicated. And eventually you'll get to a point where this makes sense, and you really want to start thinking about these in 3D. But let's just go through the basics here. I will say these tend to be a lot easier to orient than your enucleations, because usually what you'll do is have something like a lacrimal gland or a suture or something else intact, like eyelashes that'll help kind of give away your superior aspect or your lateral medial. So remember, the lacrimal gland should be on the lateral side, the duct should be on the medial side, and you can usually see that kind of in the medial canthus region. So we can orient it. We're going to measure it. We'll measure any compartments. So we can measure the lacrimal gland, we can measure the thing entirely, we can measure the lips of skin attached, and we can measure our optic nerve in the back. So measure everything you have. But the margins are really the key takeaway here, and the difference in margins. So in enucleation specimens, we had an optic nerve margin. And here, we actually have to think about our soft tissue margins. And now, to do that, we want to think of the specimen as a cube. So now we have a superior, inferior, lateral medial, and an anterior, posterior soft tissue margins. And we can ink those 6 different colors accordingly. Additionally, this skin, we can say we have an inferior skin margin and a superior skin margin. And so we can shave those. And then we'll still have our optic nerve margin. So we essentially could have up to 9 margins that we're submitting on this specimen. When we do submissions for this, what we wanted to make sure we account for is anytime we talk about a margin, anytime there's a margin in the specimen, we want to make sure that we submit a representation of that margin. Ideally, if you can get a perpendicular section showing tumor to that margin, so if the tumor is located in the superior region, I can show the tumor to superior margin, maybe posterior, maybe lateral, and I can get those. I can probably get like superior and lateral in one cassette maybe. But I want to make sure I represent all 6 of those soft tissue margins. I'll shave my skin margins and submit those separately likely. And what I can still do with this, and the other thing to think about with our posterior margin is I can shave the posterior margin soft tissue and include the optic nerve in that margin. But even with this specimen, I'm still going to try to get my PO section. Okay, that's always helpful. Even if the tumor is not interocular, it just kind of gives us a nice section to really visualize the ocular anatomy very well. So again, the name of the game is margins. Find your margins, measure your lesion of margins, and show relationships to those margins. But that's definitely a more advanced case, and I encourage you to come back to this when we start doing things like soft tissue masses or lumpectomies, and you start thinking about structures in 3 dimensions. In fact, we're going to do some of this when we do our head and neck lecture, because composites are pretty much the bones of those lectures, I guess. And that's a joke you'll get, I guess, if you're in the head and neck lecture. So that's it. A couple of CPT codes, just like we saw with the brain, going from anything from a 300 to a 309, depending on the specimen you get. So that's just something to be mindful of. But that's really it for brain pathology or neuropathology. We've covered a lot of topics for the central nervous system. There's definitely a lot of objectives to review. But feel free to come find me, send me emails, or contact me if you have any questions about the material we went over today. So thank you for joining me, and have a great day.